We will now begin with the first session of Ashtamudi Ophthalmica 2022 on cataract. May I invite Chairman Dr. V. Sahasradaman sir and Convener Dr. Rakhi De Cruz to start the session.
Good morning, everyone. So today we are going to kickstart our scientific session. Once again, on behalf of the Kollam Ophthalmic Association, we welcome you all for the participation here. This time, it's going to be a case-based discussion. So rather than just theory, this time we are going to send you all with some clinical and surgical pearls, which will be greatly useful for your everyday clinical practice. So first, I'm going to introduce to you our chairperson today. Our chairperson for today is none other than Dr. V. Sahasranaman sir. As we all know, he has been associated with Medical College Trivandrum for a long time. He was the director of RIO and he retired from RIO as a professor and HOD of Department of Ophthalmology, Government Medical College Trivandrum in May 2021. Currently, he is working as the director in academics and senior consultant of Chaitanya Eye Hospital and Research Institute, Trivandrum. He got his special training in pediatric ophthalmology under the National Program for the Control of Blindness. Previously, he was a postgraduate examiner in ophthalmology in various states, including Kerala, Tamil Nadu, Karnataka, and currently he is a DNB examiner and associated with NAT board. He has several publications related to ophthalmology in various national and international journals, and also he has various books even published with the Kerala Bhasha Institute. He is a past president of KSOS, managing committee member of AOS for the past 6 years. Welcome you, sir. Now let me introduce the hero for today. The lead speaker for today is none other than Dr. S.J. Sai Kumar sir. He will be discussing the cases regarding cataract. He is the medical superintendent and head of cataract and glaucoma services of Giridhar Eye Institute. He has been associated and is experienced in both these specialties for the past 28 years. He has presented several posters, papers, instruction courses at state, national and international conferences. He is the immediate past president of Cochin Ophthalmic Club. He has held various posts in KSOS, including editor journal, editor website, chairman scientific committee, and general secretary. Currently, he is the president-elect of KSOS and the chief organizing secretary of AOC 2023, which is going to be held at Cochin. Next, let me introduce the panelists for this session. First, we have Dr. Anup Chireth from Eye Vision Eye Hospital. He has done his general fellowship in ophthalmology from Aravind Eye Hospital, and he continued as a consultant phacosurgeon and was in charge of the medical retina department of Aravind Tirunelveli till 2002. He was the first medical director of Ahalya Foundation Eye Hospital, Palakkad. In its capacity, he served till December 2008. He was very instrumental in setting up this setup during this period. While in Palakkad, he was the president of Palakkad Ophthalmic Society, and he also helped in conducting the Drishti 2007. He had served as the president of Thrissur District Ophthalmic Society also, and presently he is the medical director of Eye Vision Eye Hospital. Next we have Dr. S. Sashigumar sir. He is a graduate and postgraduate from Medical College Trivandrum, senior consultant phacosurgeon of Cochin Eye Care, Aluva, Ernakulam. He has worked in MIC Medical College, Kolancheri, and Chaitanya Eye Hospital, Ernakulam. He was the editor, treasurer, secretary, chairman of the past KSOS. And next we have our own Jaiprasad B. sir. He is the founder, chairman of Amardeep Eye Care Centers, both in Kollam as well as in Trivandrum. Also visiting faculty at Cochin Eye Care, Aluva. He is a pioneer of phacosurgery in Kerala and the first keyhole cataract surgeon in Trivandrum. His areas of interest are in cataract, glaucoma, and in oculoplasty. He did his MBBS from Government Medical College, Trivandrum, and MS also from Trivandrum. Next, we have Dr. Sandhya. She is from Giridhar Eye Hospital. She did her MBBS from Mysore Medical College and MS from Calicut Medical College. Thereafter, she joined Giridhar and completed her fellowship there. She has won various prizes in KSOS, including the Best Video and Shiv Reddy Award. Currently, she is working as a senior consultant in cataract and cataract services at Giridhar Eye Institute. Other than this, she is a great shuttle badminton player and she has represented Kerala at national levels for shuttle badminton also. So we welcome each one of you and thank you for being a part of our CME.
So a very good morning to all of you. So we are on to the first session, and thanks to Team Kollam for inviting me to be part of this. So we have very senior, renowned, high volume, high-tech cataract surgeons as lead as well as the other panelists, and we have got a few case discussions commonly encountered in cataract surgery practice. So, as far as time permits, we will discuss a few key scenarios. And over to Dr. Sai, the lead panelist, for starting the session.
Good morning, sir. Thank you very much for this opportunity, Kollam Ophthalmic Society, Dr. Mini, Dr. Rajiv, and all the office bearers. It's a great opportunity for me to be speaking to you and discussing some cataract cases. And I'm also very happy to have a very elite panel here who have been introduced in great detail by the young Dr. Raki. The work of my fellows, Dr. Tintu, Susan, and Dr. Juhi, who have helped me prepare these videos. So we'll go on straight to the first video. Okay, so I'll give you a brief background about this particular patient. This particular patient was about 50 years old. He had sustained a blunt trauma in his right eye about a month back, following which he came with something like an acute attack of glaucoma. So he had a lens which was slightly moved forward, pressure was around 40-50. So it was presumed that it was due to a lens induced or a forward movement which is causing an angle closure. We did a PI that got relieved, and then he developed cataract, and so we took him up for cataract surgery. There was no obvious phacodonosis or the entire lens moving to one side, but this is what happened on the table. So in such situations, when you start the surgery, you see those wrinkles on the capsule, so which generally tells you that there is some weakness in the capsule, and you can see that the entire lens is moving around once you start your rexis. So I will go on directly to JP, sir, and can you just tell us the exact clinical situation, what is happening here, how you will proceed in this scenario?
Good morning. Hello. Good morning. Sai, thank you. Yeah. Now we see that once you detect that sonular weakness is quite large. One different way I do is I always start from the other side, the rexis, but not from the area where there is a sonular dialysis. I also use a 25 gauge forceps from the other spot, so that in case it's not possible to proceed, you can catch the already made rexis and then proceed with your rexis.
Any other difference of opinion at this particular point? Anyone wants to say something?
Just regarding the rexis, this is what I would also do actually.
Yeah.
No difference of opinion.
So this is how the rexis was made. So instead of using the needle, I use the micro rexis forceps. I always do a slightly smaller rexis when I handle the subluxated lenses, basically because I'm a big fan of the capsule hooks. I always invariably use the capsule hooks. There are surgeons who believe that the iris hooks are good enough, especially the Grishaber one, no financial interest. They are supposed to be as good as capsule hooks, but I generally use capsule hooks. And when you have a very large rexis, when you use a capsule hook, what happens is once you go into the eye and the chamber inflates with your phaco fluid, the hooks sometimes tend to slip off the rexis margin if you don't have enough rexis margin to hold on. So I generally tend to have a small rexis, but in this case the rexis was slightly much smaller than I really wanted it to be. But that's okay. This is a rexis that is good enough for doing a phacoemulsification. So these are the 4 paracentesis openings, and these are the capsule hooks that are being introduced. For the juniors in this audience, these hooks, if you see the configuration and the shape, they are different from the iris hooks. You have that particular curve which holds on to the rexis margin. And phacoemulsification started. Once I went halfway through the phacoemulsification, there was significant zonule pull from one side, and so I decided to insert a capsule tension ring. The general rule about a CTR is that you try to you put in the CTR as late in phaco as possible, as early before you take out the cortex as possible. So whenever it can be as late during your phaco, try to do maximum phaco before you put in a CTR. but much before starting your, your cortical aspiration, the CTR has to be in place. Any tips on that, Dr. Anup? When do you usually go in for a CTR? Do you start the CTR right at the beginning of surgery, or you would do halfway, or after removal of the...
After removal of the nucleus, as far as possible, like you said. Unless it is totally very difficult, then only we think of putting it before removing the nucleus, but it's always after removing the nucleus.
Dr. Sandhya, you want to say something?
In this case, I think I would have completed the phaco and then put CTR. And then one tips for postgraduate students for putting capsule hooks, like you can put little bit viscoelastic so that there is space between the cortex and the capsule, and then you can put the capsule hooks. And the paracentesis should be at or just behind the limbus in these cases, so that you can hold the, it will be easy to put the capsule hooks. Another thing is that these hooks, compared to iris hooks, this will give support up to the equator, whereas iris hooks will give support only up to the rexis margin. So these are the few
Shashi
things.
sir, any other comment you want to make?
Same thing. What the other panelists have said. You have to delay the CTR insertion as late as possible, but definitely after the nucleus is emulsified, it is better to put in the CTR.
So I decided to go halfway through because I don't know whether you noticed it. There was a definite the nucleus, the capsule was coming towards the phaco probe. Even after reducing the vacuum, the whole nucleus and the whole bag was coming towards the probe. So that is when I decided that I will not wait till the end, and I inserted the CTR to stabilize the area of zonual weakness there. So here the CTR goes in, and I think generally all of us know that once the CTR goes in, then cortical aspiration is slightly different. You have to go a bit tangential. If you pull radially like that, sometimes the bag with the CTR comes into view. So go a bit tangential, and here you can see the intraocular lens being implanted. This patient actually opted for a 3-piece lens, and so I've put in a 3-piece lens. But anyone would disagree? I mean, do you feel that, Dr. Shashi, you feel that a single-piece lens is better, or is there any preference, or both are the same?
No, it's always better to go for a 3-piece lens. I would prefer a 3-piece lens, and maybe you can even consider putting it in the sulcus with an optic capture.
Okay. So when you have a large area of zonual dehiscence, and we've been operating for many years, sometimes what we see is after 5 years, 6 years, generally doesn't occur in trauma, but in the progressive zonulopathies like pseudoexfoliation, what you see is once you put in a CTR, you put in an intraocular lens, and you see many cases where after 5 years, 10 years, the whole bag, CTR complex, everything moves around. I actually have a video, if you have time, we can see that moves and then gets slightly decentered, sometimes dislocated. So you have to remove the entire and then go in for a secondary IOL implantation. So that is where what Dr. Shashi said here makes sense. You put it in the sulcus and then capture it so that the entire weight of the IOL does not go into the bag. And I don't know whether there are any long-term studies which say this is better than the other. But that is, when you have large zonual dehiscence, I think that is one of the things that you can do. Dr. Sandhya is a big fan of that technique. Can you just say a few words about that?
If in generalized zonulopathy like pseudoexfoliation, I usually like to put the CTR inside the bag and then put a 3-piece lens in the sulcus with optic capture. So this sulcus in the, haptic in the sulcus gives another anchor so that the long-term stability is better. So the entire capsule CTR complex dislocation will be less. And then the optic inside the bag, it acts as a barrier for the phimosis also, and then it will be the stable position, the lens won't move. So it will be a stable position.
Okay. Any other comment?
I would sometimes, for a very severe case, I would go for iris claw lens also.
Okay, okay. So that is, any questions, comments from the audience? Can we go on to the next case? A lot of seniors in the audience.
And another thing, if you are planning a capsule, optic capture, you should have the rexis correctly centered, one thing, and it should be of adequate size, just smaller than the size of the optic, so that it will go in correctly. And second thing is, if you are putting the 3-piece lens into the sulcus, maybe in traumatic cases we should not try that because entire area has no zonules. But if you have a uniform weakness all around, probably that's a very good technique, excellent technique actually. In the sulcus and optic capsule, in case it decides to dislocate over time, if you can pick it up early, the same 3-piece lens you can anchor, or even the ring can be anchored. So
it is actually a bailout technique I have felt sometimes, because when you have a very large zonule dehiscence, you put in a normal CTR and not a sutured CTR, and you feel that even with the normal CTR, you feel that the bag is not stable enough. It still sort of tends to move out. So in such situations, I think, instead of taking it out, going in for a sutured CTR, a good option would be to place it in the sulcus and try to capture it if possible. Okay, so I think we'll move on. So in this particular case, I put it in the bag and I found that the rhexis was slightly smaller, and because there was enough counter traction due to the CTR, I made a small nick in the rhexis margin and then extended the rhexis, and this patient is doing quite well. Okay, so we go on to case number 2. This was a mature cataract with high intra-bag pressure. So generally in such situations, my technique is to go in for a double rhexis. So you do one rhexis first and then go in for a secondary rhexis. So in this particular case, what happened was, once the primary rhexis was being done, it got stuck somewhere sub-incisionally, that is at the area of the temporal, where you want to make your main incision. And so normally what I do is I finish both the primary and the secondary rhexis, and then only I make the main wound. Because in case you have a problem, you can always, if you want to convert to SICS or something, it's much easier. But in this case, I committed for the main wound. I finished the primary rhexis and they have gone in for a secondary rhexis. Now once you go in for a secondary rhexis, sub-incisional, when you come, you have to be very, very careful. So this is the mistake that I have made here. Instead of going through the paracentesis with the deep chamber, I have gone in through the main wound using a utrata forceps, and there I have got a capsule runoff there. How will you proceed from now on? Sahasranam sir, you want to make some comments?
I think we have got a very expert panelists who would be able to comment better.
Shashi sir.
No, here the problem is that you can complete the rhexis by making a nick and then complete the rhexis, and if you feel that the rhexis is intact or it can hold the maneuvers, you can proceed with the phaco. Otherwise, in my case, I would convert to an SICS.
I think normally even I would have, if there is a compromise, I would have, but here I have already committed with the main wound, so I was in a dilemma. Dr. Sandhya, you want to make some comment?
So here, first what I would do is I'll put viscoelastic into the anterior chamber so that the convexity of the capsule is means we can flatten the anterior capsule, and then I'll look for few things like whether the pupil dilates well, what's the density of cataract, and also I'll look at that flap, whether it is inverted or reverted. And then while putting OVD also, it's better to put on the peripheral side rather than putting inside the tear, because if you put it inside, then suddenly it will open up. So when you put it at the periphery, that will act as a tamponade. And then as shown here, I'll take the rhexis from the opposite.
So basically what we want to prevent here is a wraparound tear. A wraparound tear is a tear which goes from the anterior capsule margin, goes to the zonules, and then goes behind the posterior capsule. So this is what we want to prevent, especially with the entire nucleus inside. We don't want a nucleus drop, we don't want a wraparound tear. Anup.
And in this case, even if, for example, in spite of all the efforts, what Dr. Sandhya said, it may still go peripherally. So if you can just complete it so that you get like a teardrop sort of a rhexis. But since that is the weak part is sub-incisional, we can still continue with the phaco.
Okay, fair enough. Anything else? Any other opinion?
Say, first of all, in a mature cataract like this, intumescent, the first point is when you initiate your rhexis, a cruciate incision. Always, you put multiple cuts. I put multiple punctures with my 26 gauge in the central 1.5 to 2 millimeters.
That is
so
to
that you have
the,
multiple.
You want to release the intra-bag pressure
yes. And
as much as possible.
Yeah. And the chance is the entire pressure is not being not acting at 2 points. When you are initiating a rhexis like that, you have only 2 points. Here you have multiple points, so that the intralenticular pressure is distributed to all this. So the chances of that to run peripherally is less. That is one. And then once you finish your first Rex, the smaller one, I generally go in with my bimanual IA and do cortex aspiration right up till the equator. I go in and take out all the fluffy cortex, take it out, so then it becomes very easy to do your second Rex.
That I've done here. I didn't just show it. Because
Okay.
always once you do the primary Rexes, your first thing is to remove the cortex and some epinucleus remnants from the surface. Yeah.
And that too from the periphery as well. That is the point. If you take it from the center and then you leave it in the periphery, then you can have this sort of an issue. And second thing is, once it runs out in my hands, once it runs out, then I try to do the rest of the Rexes. I take out more cortex with my bimanual IA, ensure that the nucleus is loose in the back. Then I will look at it and decide whether this I can fake or not. If I think it is safely, I will proceed. Otherwise, SIC.
So bimanual, what Dr. JP said, bimanual, very important point you have to note, because your chamber is always maintained in your bimanual. So the chance of the Rexes running off is much less, and as you come out, you can use some OVD. So what I have done in this case is, I have made a small nick in the Rexes at the opposite side, and then generally finish the Rexes there. Here I'm going in through with a micro-Rexes forceps through the paracentesis, so that I don't make the same mistake of having one more subincisional. So here I decided to just lift up, because I already committed for the main wound. I didn't want to extend the clear corneal wound, then it becomes a bit mess, you have to suture it and all. So not a very ideal technique to do, but in some cases, you can bail out by lifting up the nucleus at one edge and doing a gentle phaco, using something like viscode through your left hand multiple times, and then going in for a in the back implantation of the intraocular lens. Okay, something similar, maybe just a short few comments in this video, and we can go on to different scenarios. So this is a case where a young patient with an intumescent lens, and this is somewhere you have to be always wary of the capsule. Whatever maneuvers that we discussed here sometimes doesn't work, and the moment you touch the capsule, the entire capsule splits. You all know this is called the Argentina flag sign. Dr. Anup, how would you proceed from here on?
After the sinus?
Yeah.
Okay.
Or you can say what all you will do to prevent an Argentina flag. We all know that in some cases, whatever you do, it happens.
It may still come.
But what will you do to prevent it, and how will you manage?
In this case, if the AC is shallow in the pre-op examination, one thing additional you can do, if the patient's systemic condition permits, is you can give IV mannitol. That will shrink the vitreous, you get some more space. And then fill the AC, inflate it maximum with sodium hyaluronate or chondroitin sulfate combinations, where you get a lot of low-cost things available. So in that case, and then making a small, it is possible, but like you said, whatever done, sometimes this may occur, whatever you do. And once this occurs, then of course the next thing is you try to just make a small nick in on both the poles, and just make like some semilunar.
Two hemi-rexes,
two hemi-rexes, yeah. And after that, if you that is when the trick comes, because if you are not sure whether it is gone behind, there's a wraparound. So you have to assess that, maybe prolapse out the nucleus and do a supracapsular like you showed before, or SICs if you feel that if there is even a small doubt that it has gone posteriorly, then immediately convert to an SICs.
So since it's something similar to the previous case, I think I'll just go through it. My experience with Argentine flags has been that almost always it never goes to the posterior capsule. This is my theory. I'm not very sure whether all of you will agree to it. But when you have a typical Argentine flag sign, both the capsule rip in a very uniform manner, and it just stops there. Very rarely does it go behind. Unlike a Rexis runoff at a single point. A single point Rexis runoff, if you are not careful, a very high chance for a Rexis runoff and a wraparound tear. But Argentine flags usually hold, especially if you are doing phaco in this is a very soft cataract. So all these issues of lifting up, all those things doesn't occur. So just go in with your phaco probe, and in about 5-6 seconds, the entire soft, whatever is there is out. So what I have done is I've decided to go in for the intraocular lens and place the haptics in a direction where it doesn't really hinge on those rexis runoffs there. And once you have put it inside the bag, then I do what Dr. Anup said, make a nick and make those two hemi-rexes. So they are very, very stable inside the bag, and this is what I do with the two hemi-rexes. Dr. Shashi, you want to say something? Anything to add?
No, just one comment regarding the initial rexes, that double rexes that we can plan of. If you have a micro forceps like this, it is okay, you can go through the paracenters. Otherwise, what you can do is that you can make an eccentric initial rexis, a small rexis to the subincisional part, where you are making the corneal incision. And after that, after aspirating the cortex, it will be easy to do the second rexis with the forceps.
Okay.
With the utrata forceps.
So instead of having a small round rexis in the center, make it slightly eccentric, which is more accessible from the subincisional.
From the subincisional.
Okay. So that is another good take-home point.
When you're doing phaco, you should use low parameters, like you should reduce the bottle height and then low aspiration flow rate. That is very important because you can minimize the anterior chamber fluctuation and then you can prevent further extension of the
Raki, tell me when I should stop. Yeah. Okay.
And say one more thing. I would do that rexis on either side before implanting the lens. Because you are going through a smaller area.
Okay.
So that's only different thing that I do usually.
Yeah. Normally what happens is when
and
you
always remember that it's leaving just 2 points. If you are planning to take the nucleus out from the bag, it's better to put multiple cuts and take out so that the entire stress of taking the nucleus out from the bag is not being borne by just 2 points. Chances of
that is what I said. Sometimes the 2 points holds the stress much better. Two symmetrical points holds the stress much better than one single rexis runoff.
That is true.
I think that is the point that I wanted to make. Okay, so now we move on to a case of a posterior polar cataract. This is a typical posterior polar cataract, and we all know there are various techniques to do posterior polar cataract. And one thing that I want to stress for all the juniors here is that in a posterior polar cataract, SICS is not the technique of choice. Don't think that I am not good at phaco, so I will do an SICS. You will invariably have PC problems because the biggest problem in posterior polar cataracts is chamber maintenance. You leave everything else behind. You leave the weak capsule behind. You leave all the configuration or the various types of posterior polar. The most important point during surgery that you have to look for is chamber maintenance. If you maintain your chamber properly, the chance for unless there is a pre-existing rent, then you can't do anything. But if there is no pre-existing rent, just a weak central capsule, and if you have maintained your chamber well, more than 90% of the time you will get away with an intact capsule. So SICS phaco is the ideal technique for a posterior polar cataract. And if you are not very confident of phaco, please ask one of your colleagues to manage this. Don't do an SICS. So I've done a routine technique that I usually do. I make a trench without hydro dissection and slightly separate it, and from the sides using the Sinski hook I take out small bits from here without any rotation. It's not a very hard cataract. It's about grade 2 to grade 3, and during cortical aspiration you notice that as the last piece of cortex is gone, you see the typical split in the posterior capsule. So JP sir, what all in this technique will you do to prevent a rent, and once you have a rent, how will you go forward?
In a posterior polar cataract, there are 2 points to always remember. That is, the anterior chamber should be maintained throughout your surgery. Except in a posterior polar, always the AC should be maintained. Which means when you are taking out your irrigation handpiece, always go through the side port, inject an OVD, fill the AC, and then only take out. Similarly with your phaco handpiece. That is one thing. And the way I tackle is slightly different in that, of course, rexis, everything is the same, but I use my phaco. I trench out a bowl. I create a bowl, a very thin bowl I create. I take out almost all the nucleus with, in phaco 1 mode, that is the trenching distinctly, but always with the parameters down. As you have seen, it's very low. And once you have created a bowl, I do not do hydrodissection or delineation. Never a hydrodissection or delineation.
I think that is a very valid point that sir is making. Theoretically, you can do a hydro delineation and not a dissection, but many a time it's very difficult to judge it.
Really say.
Sometimes you feel that you have done a delineation, part of it goes into a dissection. There are some people who apparently do careful hydro dissection. That means they small aliquots of fluid they put from all 4 points so that it just goes and stops at the area of the posterior polar cataract. But I think it's
I've seen
technically
such videos, but
yeah, you can,
practically
but
I've tried.
replicate it all the time. I think with various grades of cataract is I think not very easy.
Many times I have failed in doing that. So then I use a dispersive OVD. Orocort is what I am using. I have no financial interest. I go and do a hydro delineation at this point, visco delineation with a dispersive OVD. So now what happens is it goes under the bowl at multiple points, so that now we have that bowl slightly raised up. You have a layer of dispersive OVD between the capsule
Under
and
the remnant
nucleus.
of the nucleus.
Yes. So then it's very easy to do. You can go with low parameters and aspirate out that cortex. And if you detect a PC run, manage accordingly. You can make it into a rexis.
So there are various techniques for managing posterior polar cataracts. Dr. Anup, once you've had a rent, it's just like any other PC rent, or you want to make any modification or?
No, once the rent is there, I think you manage just like any other rent. Okay. But one thing I would like to tell is that in this sort of cataracts, you are sure it's a PPC, posterior polar. But sometimes, when older patients, they come with PSC also along with that. And that is when you tend to miss. And in fact, my first nucleus drop was a mature cataract. I just did a hydrodissection, it just went down. And next day, because in institutes, you are not the person doing the pre-op examination. Next day, the other eye, when you saw it, there was a PPC in that eye. So in such cases, I think when a PPC is masked by a PSC, that is the more risky cases.
Dr. Sandhya, you want to make a comment?
In these cases, the size of the rexis also is very important, because I would prefer to do somewhere around 5 millimeter. Because if the PC rent happens, then you can do places 3-piece lens in the sulcus and do an optic capture. So for capturing the lens, at least you should have a 5 millimeter CCC. Another thing is the nucleus management depends on the density of cataract also. If it is a very soft cataract, as sir told, I will do that scoop technique and then visco dissect the cortex and all and then take it out. If it's a medium hard cataract, then you can do, as Dr. Sai sir said, just make a trench and without hydrodissection or delineation, separate it. And if it's a very hard cataract, then I would do an SICS only, won't go for this.
Dr. Shashi, would you go in for a 3-piece lens, or do you think that this is a stable posterior capsule tear? Would you like to make it into something like a half posterior CCC, and would you go in for a single piece lens, or you would be safely going in for a 3-piece lens?
If you can make a posterior rexis fairly okay, then maybe you can go for a single piece, but I would always prefer a 3-piece lens with an optic
You wanted
capsule.
to make some other comment also?
Yeah, another thing is just want to ask the panelists, is there any role for AC maintainer to maintain the AC here?
There is a role for an AC maintainer just for the maintenance of the chamber, but the problem is that sometimes when you have this rent during the procedure, the fluid from the AC maintainer is directed towards the vitreous. It sort of tends to hydrate the vitreous. I have tried it once or twice. In both, whenever I used AC maintainer, there had been PC rent, and I feel that the chance for vitreous prolapse and hydration of the vitreous is slightly more, unless you can angulate it very well into the angle or something like that.
I think at this stage the most important thing is, before taking out the probe, you have to plug the area of PC rent with a dispersive OVD.
But plugging in a PPC doesn't work, because this is a large opening. Plugging is important when you have a small PC rent or a slightly medium-sized PC rent, where you want to plug that opening and prevent things from coming out. But here you have a rent which is across the eye, and a slight well separated. You can use it, but I don't think that by itself prevents a vitreous from coming out. But chamber maintenance, I think, extremely important. Rather than plugging the wound, the use of dispersive viscoelastic would be to have a chamber maintenance. Yeah.
Sorry to interrupt, sir. We are running out of time.
Okay.
I request Chairman Dr. V.S. sir to kindly conclude the session.
The time allotted was 40 minutes, but I think we started at 9:10. Do we? Anyway, because time is important.
Yeah.
Maybe we will.
So I'll just show maybe one more video and
Yes.
then I'll stop.
Yes. Yes.
So we have gone through, familiar scenario. This is one I said I will show. This was a CTR bag IOL complex which got decentered after about 5 or 6 years. This was done elsewhere, but I have managed my own cases also, quite a few of them. So what is your general technique? I'll just run through this video and then we'll have a short discussion before. So in these sort of cases where the chance for retrieval is very low, I generally, the easiest technique is to open, take out the entire bag CTR complex and go in for whichever is your favorite secondary IOL technique. It used to be glued IOL for me, but now, like many others, I am also a big fan of the iris claw. Very simple technique and very fast. So first the CTR came out, then the IOL has come out, and then these are the remnants of the bag which is firemost. That's an anterior vitrectomy being done. And in a claw, invariably I do a small inferior PI because you don't want any pupillary block in the post-operative period. And then I go in for an iris claw. There are some good forceps available for iris claw lenses. If you are using iris claw lenses in reasonable numbers, please get one of those forceps rather than trying to hold it with a normal lens holder, because quite often when you hold it, it tends to slip, and when you're trying to enclavate, the lens tends to slip quite often. So get one of those dedicated lens holders. It really makes a very big difference for your iris claw. So then both the enclavations are done. Enclavation is pretty simple, although one or two cases you feel that you don't get that correct position where you want to enclavate, but once you get the hang of it, it can be done easily. Needless to say, there are certain basic conditions that you have to have. You need to have a decent iris around pupil, not a badly damaged iris. Don't try. And in some cases, especially following trauma, you have multiple sphincter tears. The pupil is very large, so that is where probably you can think of either a sutured or a glued IOL, and then do a pupilloplasty if you want to make the pupil much smaller. Any other difference of opinion regarding this case, and then we'll stop. Any other lens you would like to? Would you go in for a sutured?
I used to use 3-piece lens sutured to the iris for a long time. I started using iris claw also in a good number. Between the two, iris claw takes lesser time. That is the biggest thing. There is a short learning curve, but you have to learn that. You can use your thin cloth and try in your OR before you start doing a regular case. Get a sample lens and try it, enclaving and disenclaving. That you can do. That is how you learn actually. And
disenclaving is not at all easy.
Yeah, it is a very tough job actually.
Enclaving is easy.
Because
So
we have.
if you want to remove an iris claw, I think that is one real
the
trouble.
issue is, surgery. There will be a situation where we'll have to disenclave, and that is when one side it has gone back. Then it's advised never to use the same lens. So you have to disenclave. So somehow you have to manage. And I have had one patient who had a refractive iris claw lens. Refractive iris claw lens. I don't know why that surgeon did that. It was a micro-ophthalmic eye. AC was very shallow. This lens was on the iris and producing severe glaucoma and iritis, and I sent to my best friend to a disenclave so that he did a good job also. And then subsequently I did the cataract surgery after some time. But what I'm saying is disenclavation. If you are doing enclavation, you should also learn disenclavation. You can do it in your OR on a piece of cloth, very thin, fine cloth that the
Disenclavation
dupatta
after
is the
some
best
time
one.
is not at all easy. 50% of time you end up tearing the iris.
I have never been able to.
It's not at all easy. Once in a while you may get
I
through
don't
it, but
manage.
yeah. Any other
just-
quick comments, Dr.
Yeah,
Sandhya,
cut the
Dr.
lens and
Shashi
do.
Kumar, before we close the session?
For me, somehow iris glow doesn't work very well. Once I had a real struggle. I could enclave one claw, but the other one I couldn't enclave. So somehow I disenclaved the other one, but there was iridodialysis, and then that time onwards I stopped doing iris glow. Whatever happens, like
No, it's a
this
very
is
simple
situation,
technique. It's a
kaide
very
I
simple
do a
technique. That
Glued
is my-
IOL or a stitched
Yeah,
SFIOL.
but those are all techniques that take a very long time. There was a lot of apprehensions about iris claw initially, that it causes chronic iritis, causes a lot of CME, you can't dilate. All these are wrong. You can still dilate the pupil very well. You can, and regarding chronic CME and all, even with a long procedure like a glued IOL or a sutured SFIOL, you still can get CME. And this chronic iritis also, I've seen in a few cases, but it's not that bad that you can't manage with some extra nepophenac or something like that. Usually I'm able to manage these sort of.
A well-measured anti-HIV also is equally good. Equally good.
The problem with, I think that point is very well taken. I'll just take 30 seconds more. That point is very well taken. But the problem is that iris claw you usually do in compromised situations. You don't generally, unless it's a secondary IOL, you don't generally plan with an iris claw lens. It happens and then you are. So definitely I feel that iris claw is better than the anterior chamber because it doesn't touch anywhere in the chamber. It doesn't touch the angle, the problem of future rotation, UGH, chronic. Definitely iritis is lesser in iris claw compared to a AC IOL. So it is the point that a well measured, well sized AC IOL is good enough is well taken. But my personal choice, I think of many cataract surgeons nowadays, is that
Because ACL, if it is not measured properly, it is hell for the patient. It's painful blind eye it becomes. That is the problem. Yeah. And in
Okay.
dispersive viscoelastic is one more thing I think I'd use with iris claw.
yeah.
Because as soon as you put the instrument, the chamber.
I generally use viscoat. I use viscoat for all my iris claw lenses. I open a viscoat even if it is not opened on that day, just for this, and then include it and then wash it properly. It doesn't come out very fast. Wash it properly. Okay, thank you very much. Thank you for the opportunity, Kollam Ophthalmic Society. I thank my elite panel, Sahasranaman sir for chairing the session, Raki for coordinating the session very well. Thank you once again.
So thank you. We have come to the end of the first session on cataract. Thanks to the lead panelist and to all the panelists. Thank you all.
May I request Dr. R.R. Varma sir to hand over the token of appreciation to Dr. V. Sahasranama sir. Dr. Sai Kumar sir. Dr. Shashi Kumar sir. Dr. Jayaprasad sir. Dr. Anup sir. And Dr. Sandhya madam. Let's have a short quiz. I invite Dr. Ajit Burgess sir to conduct the quiz.
Everybody can answer, especially from the postgraduate side. This is a simple question, no need any IQ. This handsome guy, everybody know this Brad Pitt. He has a specific ophthalmic condition. Already answers given. Can you tell and what is this and what is the reason? Just somebody can take the phone and answer. Is it dyslexia? Is it agraphia? Is it simultagnosia or prosopagnosia? It's a type of agnosia. Very good, that's it. So that is, what is the reason? This is the reason. It's also called facial blindness. This man maybe see a person in the morning breakfast, and afternoon when he see him again, he can't identify him. There's some problem in the cortex. There are the two types, acquired and congenital. Congenital, there is no reason. Acquired variety, there's a cortical maybe lesion in the fusiform gyrus. So this is only interesting situation. Next one. These are, the picture shows bloody tears. What is the name? Maybe it's a dacryorhinorrhea, dacryohemoria, hemolacria, lacrimae crunte, or hematic epiphora. And what may be the reason? Please. Yeah, its own answer. Chocolate goes to her, half chocolate only. All are the answers. Oh. So reason being uncontrolled hypertension, severe epistaxis, or any pyogenic granuloma in the lacrimal sac or something. Sir, is enough or we'll go? Yeah, only just a lighter session. Thank you.
Thank you, sir. After the exciting cataract section and quiz, may I invite Chairman Dr. S. Sashikumar, sir, and Convener Dr. Balagopal to start the glaucoma session.
Thank you, Kollam Ophthalmic Club, for inviting me for this glaucoma session. Without wasting time, we will straight away proceed with the introduction of the faculty.
Thank you, sir. So our chairman is Shashikumar, sir. He has been introduced already. Only thing left out is that he is a native of Kollam, and and we have a very eminent panelists today with us. First, I would like to welcome Dr. Smita Narayanan. He is also very familiar to us. She is currently editor KJO and assistant editor IGO and a professor at RIO Trivandrum. She has special interest in glaucoma and research methodology. Next, I would like to welcome Dr. Meena Nair, senior consultant at Chaitanya Trivandrum, a fellow of Bangalore West Lions Eye Hospital, and she is actively involved in DNB training and PG training programs. And also, next we come to Dr. Kiran Gopalakrishnan, an alumnus of AIMS Delhi and a recipient of Best Resident Award there. He has completed his fellowship in glaucoma from the same institute, currently a senior consultant at Precise Specialty Eye Care in Trivandrum and a regular faculty in instruction courses in KSOS Drishti. And then we have our lead panelist, my teacher, Dr. Thomas George. He is currently chief of the glaucoma clinic at Chaitanya Trivandrum and secretary of the Trivandrum Ophthalmic Club. Previously, he has been website editor of KSOS. And I welcome you, sir, to please start the session.
Thank you, Kiran. At the outset, let me thank Kollam Ophthalmic Club for bringing us all here to again. And I'd like to acknowledge that most of these cases actually are Dr. Meena's. So credit should go more for her than me in terms of the cases. I go into the first scenario, that is, we had a patient being referred to us from a corporate hospital, was in the ICU, referred to us with a note saying it is acute closure. And when we look at it, sick patient, pressure is 14 and 4 in the acute closure eye. Of course, there's cynical closure to a certain extent there, but we are dealt with the patient with hypertony when it is said to be acute closure. Dr. Smita, why did it happen? Kiran, if the other mic is working, please give.
Good morning. So this is a patient who had an acute attack, but probably since the patient was treated for status asthmaticus, the patient must have had some drugs for asthma, which could have been a drug-induced attack. Probably the management with Dorzox and Brimo must have brought it down. That is one reason. Or it could be a ciliary shock which could have brought the intraocular pressure low to this level.
It was a ciliary shock. Thing is, they had given mannitol, Diamox, everything, and then started this and sent it over as soon as they could.
For status asthmaticus also they give mannitol. Okay.
Whatever. They lost, I mean, this is something that happens to all of us. When we see a pressure of 50, we start everything under the sun, and next day we have a pressure of 4. And this is that eye. But more importantly, see this. It's gone to hypertony with a ciliocoroidal effusion. So now, that brings us to other eye, which is a regular closure. You can see the pupillary block configuration also here. And now we have a post-acute attack, ciliocoroidal effusion, hypertony patient. Kiran, have you seen this before? No. It comes.
And I've had patients with pressures of like 10, 12, but no pressures of 4 and a ciliocoroidal effusion. No.
Ciliocoroidal, meaning it's not a bullous choroidal, but when you image it, you find it. It's in hypertony basically. Will you do a laser PI here?
Well, the original problem of pupillary block would still persist. So, yeah, PI. But in a hypotenuse eye, that would be very, very difficult. That is.
Meena, when you want to do the PI? We have agreed. Closure, acute closure, we need a PI.
Actually, the patient being aberrant, when you do a gonioscopy and you find there is significant cynical closure, then if there is corneal clarity, which she had, I think you have to do a PI. Again, one more thing I can tell you is that when it is unilateral, if it was a drug-induced effusion, we expect it to be bilateral. And this anterior picture shows the other eye as absolutely having no effusion at all. So we...
No, the question is, would you do a PI with a pressure of 4?
Yeah, I think...
Would you use a lens there?
It is difficult doing with the lens.
Yeah. Smita, would you differ? Because I would differ.
It is true that it would be very difficult to do a PI in this instance. Perhaps after a few weeks, or 1 or 2 weeks or 10 days, when we find that the pressure is normalizing, then the PI is the only way to eliminate the relative pupillary block. So
I would tend to agree with that. What I would have done is the fellow eye PI would have happened on the day 1, but I wouldn't wait weeks. I would see the patient every 2 days. And the moment the pressure is above 6, you got a less edematous iris, I would go in for a PI. Otherwise, you're looking at any multi-session.
Pressure should normalize within a couple
of days. Couple of days should do. Get out of the Diamox and mannitol. I mean, we may stop all these topicals also. Remember, one disease does not preclude other disease. And if we had gone further without evaluating, this is what is sitting at the back of that acute angle closure eye. I think another session deals with this, so we'll leave that alone. We go on to, I'm trying to run through cases, so I'll go a little fast. Case 2 is a female on antipsychotic for 2 years. That is important because of what she did later on. Gradually progressive defective vision in one eye she had noticed, and by the time she came to us, it's hand movements, and she had practically ignored it for 2 years. And we have clear cornea, obvious high pressures, obvious appositional closure, and one eye is practically absolute, other eye still got hope in terms of 0.4 cup. And we did PIs, made no difference to the angle. Possibilities. Go ahead.
So if you do PI and it doesn't make any difference, the possibilities are that there could be a plateau iris, or it could be a large lens, or again, since she's on drugs, it could be bilateral ciliocoroidal effusion. So that's what I think. Or it could be a thick iris, but that is something which you have seen.
Shashi sir, would you want to add anything? Here, I wouldn't think of drug as a top of the line differential, because one eye is already 0.9, so you know that started earlier. It's asymmetric to start with. So, nothing specific. Okay, Kiran?
I think it was complete cynical closure, right, in one eye?
We couldn't open it up.
Yeah, even after PI.
With indentation, with PI, we couldn't open up the angles properly. And
the
right eye was complete cynical closure.
Yeah, that's right. The pressure differential is also like right eye just 48 and left eye 42. That
Slightly
kind of thing.
different. We should think of secondaries also. This is the left eye UBM OCT. There is both the possibility of a plateau and this is a lens vault. Iris root to iris root, scleral spur to scleral spur, and how much of the lens sticks out, that's about 1 millimeter. So, Dr. Smitha, practically clear lens.
Yeah, that is again a very difficult situation. You have a plateau iris-like situation here, and a clear lens with a large lens vault. Maybe I would try pilocarpine.
The large lens vault creates a problem because that would bring the lens forward a little more, pilocarpine. So, pilocarpine I didn't consider as an option. Meena?
I think with the pressure of so high and not amenable to
We have to do
PI,
something.
we have to take out the lens. Clear lens extraction probably will be helpful when you have a high lens vault.
What did you do in the right eye?
Right eye she gave up, we gave up. No pain. No pain, no vision.
Okay, hand movements. Okay.
That's why I brought in the psychiatric illness to start with. It has a bearing on the case. So the options, this is, by the way, the one and only clear lens extraction that I have done. It is not a take-home message that you see a closure, you take the lens out. Anyway, it worked. And that is closed angle, opened up. This is why I didn't commit on the cyanic again, because it opened up post-operatively. That's what it is. Here, that's where the ankle structures are. If the triangular part has come out, it's actually opened up. So high IAP, despite a patent PI, think of plateau iris number one, high lens vault. You've got anterior rotation of ciliary body as an option also, and consider clear lens extraction. But I would say in this medical legal situation, you have to document the lens vault before you go about it. You need a good
But
OCT
this
for
would,
that.
this would still be an exceptional case because, I mean, immediately your thought process goes back to the Eagle study. But we still did a PI first and actually tried
Yes,
this.
absolutely.
Unlike where this was
Absolutely.
not a choice between PI and a clear lens extraction.
It would be indefensible in court if you didn't do the PI also. I would say that also in these situations.
You can quote the Eagle study to be defensible in court. I mean, I'm just saying.
Eagle study, the
I mean,
Singapore,
but still.
that analyst study, ZAP, everything is there. Okay. So this is a case that is relentless progression is what I'm bringing in. In 2016 was a disc suspect we thought we can watch. But 2018 we had a disc hemorrhage and now we called it a possible glaucomatous optic neuropathy starting. NTG suspect, we did the works, nothing. And this is 2020. Minimally progressing visual field defect was there between 2018 and 20, and here you have your disc hemorrhages. Again the other eye disc hemorrhage. DVT is 8 to 16, and eventually it clears up, leaving behind your NFL defect. It's all the classical things happening here in an NTG. We have pressures of 8 to 12, no other risk factors found out. There is the OCT comes in, the fields are progressing, we're watching this patient, so how would you proceed? Kiran, take it up.
Yeah. So how many medications is the patient on already?
His pressures are 8 to 12. Medications deal with
But
only pressures,
You've
PG
already,
and log.
okay, but you've already looked at all the other comorbidities,
No
migraine,
carotid,
Raynaud's,
no
carotids.
OSA, nothing. Alter normal, blood works normal,
I mean,
systemic normal.
with NTGs, when you look at literature, whatever you do, certain percentage of patients will progress. So, put the patient on maximum medical therapy because, and if still progresses, go for a trabeculectomy. That is the
No,
only option.
medical therapy is all aimed at IOP. So once you've got low teens IOP, what do you achieve with medical therapy?
Yeah, but
You have nothing to do. So
still do a filtration. I think that is pretty much the only option. When you have somebody who is progressing in front of your eyes with these kind of pressures, and as long as you have otherwise optimized systemically everything else, I don't see any other option.
Yes.
If you say you have ruled out all the causes for NTG, then there are some, I think, very rare things which we might not have found out because the patient is still progressing.
I haven't done an LP.
Possible, because they
Absolutely.
talk about cerebrospinal
Low
fluid
CSF pressure is a big risk factor. But what do you do if you find a low CSF pressure?
Yes,
I don't know.
With medical management, you can go only up to 8 millimeter. You can't go beyond that. So as Dr. Kiran said, maybe you may have to try a trabeculectomy, which would be very difficult because it might go for hypotony anytime. So
The Koreans and Japanese have a lot more NTG than we have. Yes. And those surgeons do trabs aiming at pressures of 6. Would you dare to do it?
If you have a patient progressing, then
it's a fine line.
It's a very fine line. It's a very
starting
fine
at
line.
8, you want to make it 6. Medically not possible. Sai.
I think more than the pressure reading itself, I think the once you do a trabeculectomy, the intraocular pressure fluctuations would go down significantly. I think the pressures will remain at a much lower level.
That's a point. You can have a safety valve and hopefully you won't have that 8 to 12, it'll stay at 8 at least.
Yeah, and once you do a trab and you follow patients up, as long as the pressures are remaining at these levels, generally they don't progress. That's a fact.
No, I think I would definitely start a prostaglandin analog first in this case.
It's already on.
With this pressure, we have done it for the sake of giving something.
And reducing from 8 to 6, I don't know the predictability of a filtering surgery other than what Kiran said about avoiding the fluctuations in intraocular pressure. I don't know. How many times out of 100 you can predict
I don't dare. I haven't done a trap.
Predict that from 8 it will come to 6 and stay there. I don't know. I really don't know.
No, I think
the problem is if it goes under 6, you got other hypertony coming in.
Hypotony may not actually happen for these patients because there are patients with 12-14 millimeters of mercury following a valve surgery that I've done about 3 months back, who is actually hypotenuse in terms of having choroidals.
Yeah, so, I got 12-14 when I brought it down from 40 with exudative RD.
About 50.
With exudative RD needing vitrectomy.
Yeah, so again, I mean, I haven't done traps in such cases, but if you are documenting progression and you are showing the patient that your actually vision is going down in front of your eyes, I think there is a serious discussion to be had, and certainly this.
Probably do one eye and let's see. That is probably, I mean, it will be a very long discussion because hypertony has to be really explained to the patient. And like Kiran said, because the drop is not that high, it may not get clinical hypertony. That's a possibility. So what we have been doing is, we've been lucky so far. We don't have to make the decision because the progression seems to have stopped. Pressures are still the same. To get anything genuinely lower, you need a trap. Here,
can I just
yeah.
I just want to since it's my patient, I was remaining silent. But what happened here is, I would say, one should revise one's gonioscopy, because this patient had wide open angles to start with initially when the diagnosis of a tilted disc was made, and gradually it was going into a little bit of, say, opening up to the PTM in one quadrant, having a small change in its iris curvature towards the periphery. And what was missed was a regular gonioscopy because it was taken for granted. And finally, when the maximal medical treatment was done, when the patient went for recurrent hemorrhages, a revision gonioscopy revealed a plateau iris. So a laser iridotomy was done in this patient,
also added on.
and probably that curtailed further or arrested further progression between 20 to 22.
Possibly.
EVT of 8 to 16 might
a
suggest
recurrent
some
closure can mimic an NTG unless you're doing yearly gonioscopies at least.
Yeah, that is something I found a little missing.
Creeping closures, plateau iris,
No,
these can come in slow.
Is something you find missing in the recommendations. If you look at all the For example, the Asia Pacific Glaucoma Society, they say you should do gonioscopy regularly, especially in the case of angle closure glaucoma. It should probably be the other way around, because once you do a PI, whatever you can manage in angle closure, you have already done. But it is the open angle once you have diagnosed once, which over a period of time actually starts going,
I am a person who says that you cannot diagnose an open angle glaucoma without a gonioscopy.
not the diagnosis.
No,
It's what
even
after-
diagnose, because your prerequisite is that it's an open angle. Unless you've seen it, you can't say it.
No, what he says is
What I'm saying is, like in
Follow-ups
2010,
also,
you have
follow-ups also.
diagnosed open angle glaucoma. The emphasis on follow-up gonioscopy is for angle closure glaucoma patients once you have done a PI and all, even in the recommendations. But it is one patient who have diagnosed as open angle in 2010 actually would show some degree of iris bowing and slow creeping closure like in 2020. So I would personally feel that a follow-up gonioscopy at a specified time period would probably be even more important in an open angle, because there is something for you to do.
Yes.
Sir, one more thing. Some patients have anteriorly inserted zonules onto the lens. So in such cases, shouldn't we also think of a pigment dispersion which may be happening and pigments may be getting absorbed probably?
I have also noticed these anteriorly located zonules even up to the anterior pole of the lens, and the zonules are pigmented, but then I am not sure if it causes extra pigment dispersion in terms of pigment at the angle. And it does cause pigment dispersion, because I've noticed that some of the closures where you indent open the angle and it's heavily pigmented, those guys, when you come for cataract surgery, you have these zonules all the way to the front. But I have no literature to back me up. It's only personal seeing it. That's what I mean, no? Sometimes zonules come all the way to the anterior pole of the lens. Sai, you're older than me. Have you seen any of those? Okay, this patient, again, the first statement is not to malign the patient. He is running a business in the Gulf, actually. He had left eye decreased vision. He decided his cataract and came over with a 1-week trip plan to get the cataract done. And when he was evaluated at that hospital for the cataract, a closure with nuclear sclerotic cataract was found, and IOP was 50. They did a PI. IOP stayed at 50, and they referred it to me. Post-PI, persistent closure, no prior symptoms of angle closure, and the discs are healthy, 0.4. Any thoughts yet? It's a uniformly shallow AC. It's not a pupillary block AC.
This is only in one eye.
Actually, only in one eye. Other eye is moderately open angle. It's not a very wide open angle, but it's not a closure.
And this is a post PI where you cannot open it up with indentation.
Yes.
So you are
I
seeing
see it
synic.
post PI. It still cannot be opened up with indentation.
So it's fully synically closed.
That's the ubium. It's a uniformly shallow AC. Is that a pointer? Sai, you're bang on. It's not post PI. It's
Malignant
de novo. Because it came like this apparently to the first hospital. Okay, it's uniformly shallow AC. The two things that I would think of is, one is a subluxated lens. That would be my first thought. The second one would be, because I've seen it in the past. That's why. Anyway, he has no time. So, no definite synechiae. We couldn't indent it open. PI patent, uniformly shallow AC. I dilated the patient with tropicmet, keeping him in our OP. And the pressure dropped to 30 in 1 hour. That is why I'm calling it malignant glaucoma. I haven't had much time to. Malignant glaucoma is not a diagnosis you make in one day. You have to see how it responds, and that's how we make the diagnosis. And I sent him off on atropine in the remaining 4 days that he gave me to treat him. And 2 days later, the IOP was 10. I was also surprised. And he's gone back to the Gulf, promising to come back sometime in Jan, maybe Feb. Okay, this is what it is. it's not a very good UBM picture, but compared to the this picture, the AC is deepened, some amount of opening has happened, and even on the side that doesn't seem to be open, there is a slit that's available all the way to the periphery there. I hope it takes time. Atropine takes time. I'm just hoping that it works out. He's gone to the Gulf again with atropine, and he's sort of agreed to come in Jan, but most likely only by March. Told him to keep checking his pressures there.
So what do you plan to do when he comes back in Jan 2023?
Anterior vitrectomy before I do the cataract and the cataract. That should work.
It should work. I'm just saying that how do you do the cataract, extraction?
You have to first deal with the posterior misdirection. Sai. There are people who would go for a proper core vitrectomy by a posterior segment surgeon.
I've had at least one gentleman like this whom I did cataract, did well for some time, but then progressed a lot of something like a cynical angle closure. I lost that eye. He had the same thing in the second eye.
Yes,
Similar
fellow has come the same way.
Yeah, similar picture in the second eye. Then I think Dr. Mahesh also came in with me. We did a good vitrectomy. That eye stayed for a few years before he passed away. So I don't know what.
Which prevented you from having more
Yeah. I don't know whether the second eye would have gone the same way, but these are really, difficult, tricky situations.
So that eye they did a full vitrectomy, core vitrectomy?
Second one, core vitrectomy, not a complete vitrectomy.
Or was it just like 23 gauge entry into and just a little vitrectomy?
But enough vitrectomy to, the first eye we did vitrectomy on afterthought.
Was it done with a, with a lens on so that they could see the entire?
Yeah, I think so. I mean, I don't exactly remember. It's for about 10 years back.
Practically, what I would be ending up doing is you go in because you can't really see too well. Do an anterior vitrectomy enough for the lens to move back. Do the cataract. Then you go back and make sure you got a single chamber.
Okay.
Punch off a little bit of the PC also. I do a classical Chandler, so I make the stab also. I mean, now the preferable thing is to get a posterior segment surgeon involved and do a core. That's why I didn't talk about that. Okay.
Sir, one doubt. Can you please explain about the anatomical predispositions in such an eye? What is causing this de novo malignant glaucoma? Is it a anteriorly positioned ciliary process or something else?
It's very difficult to say. Any closure eye can go into a malignant glaucoma. This is all postulates, so there's no proof. What they say is the ciliary processes get opposed to the lens equator, and then the misdirection starts. So if you've got an anteriorly positioned ciliary process, long ciliary process, all that's possible. More than that, if your ciliary body is rotating anteriorly, which happens in some patients, it can happen. So quite often it is usually a hypotony that starts the whole show off, where the ciliacoral effusion starts, now it gets stuck and the positive feedback, the aqueous misdirection, pressure goes up, and they claim that if you press the vitreous, it becomes less permeable to water, and the whole thing traps behind. I myself have not fully understood. So
hypotony should be usually a predisposing factor.
Usually the start is a hypotony.
Yeah, post angle closure glaucoma traps are more likely to end up.
Yes. You get a coronal effusion and 2 days later you got a malignant glaucoma. Okay. You got a 60-something-year-old person on maximum treatment, all drugs possible. Now it will not be, because now we got the option of a 5th drug. Decrease the vision for 5 years, pressure 17, 15. We are anyway going in for cataract surgery. These are the fields, pretty advanced in both eyes. What IOP would you want to have in these patients? We have medically achieved single pressures of 17 and 15. What would be our ideal IOP? Dr. Meena.
The classical teaching is you go up to 10 to 12 in such advanced glaucoma.
But is there any documented, any progression of this field?
You want to wait for a progression in such advanced?
No, I got serial pressures on him. It's around 15, 16 in the left eye, and the other one is 17, 18. And the field progression was there over 6 months. But then you got long-term fluctuation, you can't be sure. Can't afford to wait for a big proper progression by this time. And when you get a point pressure, you're assuming it's 2 above and 2 below at least. So the 15 is actually 17 in your mind.
So, I mean, I just want to know if the patient's medically, if it's not medically controlled, at this point, as you said, that there is a progression, and then we'll have to do a combined phaco.
So that's exactly what I did. And 2 weeks post-operatively, I had a blood 14 pressures. It was looking like it was not flowing too well when you massage, so I tried a suture lysis, can't see the suture, so not possible. So starting to insist, and now the pressure has reached 20. Continue the steroids. This is what it is. It's obviously delimiting and scarring down. So what did you do next?
You have to needle because it's 3 weeks post-op. Already the blood
I
is
thought so
5%.
too. So insisting, needled. Anyway, I don't need the needling video. Let me get out. 4 days post needling, good blood. 8. 1 week later, 3. Shallow choroidal effusion. Smita.
I have given atropine also. Maybe
Hello.
you can try
Hello.
systemic corticosteroids.
You're in a catch-22 situation.
Yeah.
You have to bring the pressure down, and when you do it, you go too far.
Very low with a choroidal effusion.
So now we got choroidal effusion. So I mean, atropine's on. Mitomycin.
Mitomycin. So I thought you have given mitomycin.
I had given up five long back. Anyway, mito takes time to come in. This 1 week down the line is cutting the sutures and lifting the flap and all that. Too much flow. When would you intervene surgically? You got ciliary effusion, hypertony.
Are you thinking of giving corticosteroids systemically?
I didn't in this patient, I managed otherwise. Anyway, it's a transudation here. Hypertony is a transudation. The steroids do reduce the inflammatory component, but that's not the bigger issue here. Kiran, when would you intervene and what would you do?
Once you have a choroidal effusion, I try to delay intervention as long as, you know.
Yes, you can wait a few weeks, maybe even 2 months, unless it becomes.
If there is a kissing choroidal, or there is a choroidal hemorrhage, or I mean there is definitely
Kissing choroidal from the posterior segment point of view, and flat AC, the IOL cornea touch, we can't afford. So these two would be the definite indication to go in and drain. Anyway, it became like this. Diffuse blood. About 30 days post needling on atropine alone, pressures were 10, choroidals disappeared. Both surgeon and patient were relieved. Okay, this is another 65-year-old patient on treatment already with topical medication. Systemically, he's got enough problems. Baseline intraocular pressure was 8 to 10. We got the patient on treatment already. Open angles, but visual field progressing in our hands. Again, apparently normal pressures. OAG treated, normal. What next? Kiran.
What's the IUP now?
8 to 10.
8.
It's very low. IOP is not the catch here.
This is only on on a PGA. Patient is on a
Meena, your patient. I think it's only on PGA.
So if the patient is progressing, then probably some vascular component has to be thought of.
Yeah.
Three things: Raynaud's, sleep apnea, and okay.
Turned out to be an OSA. That is one thing that we forget. I mean, I always ask the patient's spouse whether the patient snores. There's no point in asking the patient himself. So, CPAP sorted out the issue. Actually, the fields did
Sorry
show...
to interrupt, sir. 2 minutes more.
2 minutes more. I'll skip the last case. Yeah. So, it showed a little bit of improvement on it. Actually, the last case also the same. He was already on CPAP. But there was an issue with the mask. The CPAP mask was leaking, and once that was replaced, he stabilized.
TG, just one comment. The previous case, you talked about 5 drugs. So, what is the take-home message for the audience here regarding medical management?
Personally,
because these 5 drug patients, the ocular surface is really, really bad. You have all the, the right from bimetoprost to brimonidine to and then you add your rho kinase inhibitors, and do you really recommend that 5-drug regimen unless there is a contraindication?
Absolutely
or you would operate?
not. Your first drug gives you about 30-40%. Even if the second drug is capable of doing it alone, it'll give you only about 10-15. The third drug, you do not expect more than 5%. So fourth and fifth are just for your satisfaction that you're giving. Believe me, by the time you reach 3 drugs, it's time for a trab. And doing a trab after 2 years of 5 drugs, Sai, you know what results are.
It's really worse. It's really bad. The amount of conjunctival inflammation and chance for blood failure is so high that, so I think that is something that when we talk of these 5 drugs, I think that should not be a standard at all.
Even exposure is a problem with prostaglandin orbitopathy and the lid being like a cardboard. You can't retract it enough to see the superior part. It's a mess. So I would personally say go till 3rd drug. Not more than that.
I think about this 3rd drug, the only thing which is now described in literature, I'm sure had some personal experience, is that with the rho kinase inhibitors, sometimes they tend to produce a disproportionate reduction in pressure when other drugs don't work. Like if you have 2 drugs, and if you want to add the 3rd drug, and this is your last chance before going for a trap, you might as well try a rho kinase inhibitor as long as it doesn't mess up the conjunctiva.
Don't keep adding.
Don't keep adding. As the 3rd, I mean, if you're already on 3 drugs,
you don't have much of an effect with one, take it off, add the next one. Yeah. That's okay. But what happens in the typical prescription is PGA, beta blocker added, then you add brimonidine as, combination, then you add the carbonic anhydrase inhibitor, and then you add the rho kinase. You don't take anything off. Take it off.
I think 2 bottles usually more than enough.
Yeah,
if it's
2
not,
bottles, 4 drugs is possible. Yeah. That's good enough.
Beyond 2 bottles, it's probably not very possible to control.
And it costs the patient a lot more than actually getting operated. Yeah, we'll wind up here.
Thank you. Thank you, Thomas George, for bringing out some challenging cases worthy enough to be referred to your enemies. And you have shown it how well it can be managed. Thank you. Thank you for all the panelists for that good discussion.
Thank you, sir. May I request Dr. Radhakrishnan, sir, to present the token of appreciation to Dr. S. Sashikumar, sir. Dr. Thomas George, sir, please. Dr. Smita Narayan, ma'am. Dr. Kiran Gopalakrishnan, sir. Dr. Meera Nair, ma'am. Thank you, sir. Again, I invite Dr. Ajit Varghese, sir, for a short quiz.
We'll go on the lighter session again. Actually, Dr. Thomas George made our brain not warm, it become hot now. And it's our, not the intraocular pressure alone, the brain pressure also very high. So we have to go for a lighter questions now. See, can you connect these pictures with a diagnosis? Oh, it's very faster. No, I didn't. Can you connect? Moonlight, bone-like stuff, candle wax. Points to one diagnosis. That's it. Retinitis pigmentosa. Night blindness, bone spicule, waxy pallor. Chocolate, sir, please, sir. I want to introduce two persons. Discoverer of the slit lamp. Yes, done. Sir. Oh, one more. This is Rangasamy Srinivasan. What is his contribution to ophthalmology? That's it. Sir, chocolate please. Because he was working with ultraviolet rays, then he switched on to excimer laser, found it's useful in photo disruption and is the base for LASIK surgery. So in Indian. One more last question. Yeah, one question our practical. Oh. Yeah. We are most of the practicing ophthalmologists are giving driving license to people with even one eye blind. Question is, can we give driving license to people having homonymous hemianopia? Even if one eye is blind, we can give driving license. But what about the people having homonymous hemianopia? Okay. You can't. Sir, answer please. What's the reason? Yeah. Probably because they need a continuous field. Yeah. So this is the reason driving regulation require continuous visual field over a certain size. Is it okay, sir? We will go. Thank you.
We will now begin with the formal inaugural ceremony. I invite the following dignitaries to come out to the dais. Inviting Kollam Ophthalmic Association President Dr. Mini Jayachandran, President-elect KSIs and our Honorable Chief Guest Dr. Sai Kumar sir, Organizing Committee Chairman Dr. Nisa Madam, Kollam Ophthalmic Association Secretary Dr. Shaini Napoleon Madam, and Organizing Secretary Dr. Divya Kishan. We request Mrs. Suvarna to begin the ceremony with a prayer song. All of you please raise for the prayer.
ഹരിത സുന്ദര സന്നിധി തിരുനാഥനെൻ്റെ പ്രണാമം അരുണശോഭിതവാനിധി അതിനാഥനെൻ്റെ പ്രണാമം ഹരിത സുന്ദര സന്നിധി തിരുനാഥനെൻ്റെ പ്രണാമം അരുണശോഭിതവാനിതേ അതിനാഥനിൻ്റെ പ്രണാമം പുലരിയുണരും യാമം മമനാഥനിൻ്റെ പ്രണാമം ഹരിതസുന്ദരസന്നിധി തിരുനാഥനിൻ്റെ പ്രണാമം അരുണശോഭിതവാനിതേ അതിനാഥനിൻ്റെ പ്രണാമം താരിളം പുൽക്കൊടികളെ തഴുകുന്ന സാന്നിധ്യം പൂവിതൾ തൻ കവിളിലും വിടരുന്ന സാന്നിധ്യം താരിളം പുൽക്കൊടികളെ തഴുകുന്ന സാന്നിധ്യം പൂവിതൾ തൻ കവിളിലും വിടരുന്ന സാന്നിധ്യം മേഘമായി ചെറുമാരിയായി മനതാരിലൊരു കുളിരായി നീ സാന്ദ്രമായുന്നനുപദം അണയുന്ന സാന്നിധ്യം ഹരിതസുന്ദരസന്നിധി തിരുനാഥനിൻ്റെ പ്രണാമം അരുണശോഭിതവാനിതേ അതിനാഥനിൻ്റെ പ്രണാമം.
Thank you, Mrs. Suvarna, for the soulful prayer. We invite Dr. Nisa Madam to deliver the welcome address.
Kollam Ophthalmic Association President Dr. Mini Jayachandran, Secretary Dr. Shaini Napoleon, President KSOS Select Dr. S.J. Sai Kumar, Oration Awardee Professor Dr. V. Sushila B. Nair Madam, Lifetime Achievement Awardee Balashnan Sir, Govindan Sir, Senior KSOS members, Organizing Secretary Dr. Divya Krishnan, distinguished faculty members, my dear friends and fellow ophthalmologists. A very warm good morning to all of you. Kollam Ophthalmic Association is extremely happy to organize and present this academic feast. It is indeed my privilege and pleasure to welcome everyone to this our 6th Ashtamudi Ophthalmica in a physical mode after the COVID-enforced break of 2 years. Today we are having this case-based discussion covering cataract, glaucoma, retina and oculoplasty. We have with us today our chief guest, President-elect KSOS, Dr. S.J. Sai Kumar, the Senior Cataract and Glaucoma Consultant, Giridhara Institute, Kochi. On behalf of the organizing committee, I extend a warm welcome to you, sir. I am honored to welcome the Oration Awardee this year, none other than our Sushila B. Nair Madam, Senior Consultant, Kerala Institute of Ophthalmic Medical Science, Kerala Institute of Medical Science, Tirunelveli, who is here with us. She is awarded the prestigious Dr. S. Mohandas Memorial Second Oration 2022. The first oration was delivered by Dr. R.D. Ravindran, Chairman, Aravind Eye Care System. On behalf of the organizing committee, I extend warm welcome to you, ma'am. This time, we have two personalities to receive the Lifetime Achievement Award. I would like to extend warm welcome to the awardee, Dr. K. Balashnan sir and Dr. K.S. Govindan Nair sir. I welcome our KOA President, Dr. Mini Jayachandran. A warm welcome to you. We have esteemed faculty members today. I would like to welcome all the invited eminent faculties and the panelists who agreed to spare their time for our CME on this Sunday. I extend a hearty welcome to all the invited guests, all the delegates, and all the sponsors. I hope everyone will enjoy the section. Have a great academic feast. Thank you all for being a part of this.
Thank you, Madam. We invite Dr. Mini Jayachandran Madam to deliver the presidential address.
Good morning and warm welcome to all. Respected dignitaries on the dais, our chief guest, Dr. S.J. Sai Kumar. He doesn't need any introduction. He is a well-known ophthalmic surgeon and is the President-elect of Kerala Society of Ophthalmic Surgeons. Organizing Chairman, Dr. Nisa. Organizing Secretary, Dr. Divya Kishan. Kollam Ophthalmic Association Secretary, Dr. Shaini. Dr. Sushila B. Nair, winner of the Dr. S. Mohandas Memorial Oration Award. She is a senior ophthalmologist in KIMS, Trivandrum. She is a great academician, teacher, and a very good human being. Lifetime Achievement Award winners Dr. K.S. Gobinathan Nair sir and Dr. K. Balakrishnan, who they have been with us in all our activities. And all speakers, panelists, and delegates who have come from different parts of the state to take part in the CME. The present team of Kollam Ophthalmic Association took charge on 15th March 2022. Dr. Arup Chakravarti, KSOS President, was the chief guest. After that, we had a series of activities. During the glaucoma week in March, almost all eye hospitals in Kollam conducted screening program in the form of camps, health education and awareness programs. In the month of April, we had a CME on primary angle closure glaucoma. Dr. Thomas George was the speaker. In May, we had a CME in which an ENT surgeon, Dr. Sunil, spoke on medial orbital wall. In June, we had a CME in which Dr. Meena Nair was the speaker. She spoke on practical approach to medical management of glaucoma. In August, we conducted an online CME on phacoemulsification in association with KSOS. It had good viewership. The next CME was on basics of ICL surgery by Dr. Sapna Nair. During eye donation fortnight, Kollam Ophthalmic Association conducted an online awareness program on do's and don'ts in eye donation. The speaker was Dr. Anil Radhakrishnan. The Kollam Ophthalmic Association, which was a small association to begin with, now it has a membership of 75. We have a new team of young, vibrant ophthalmologists who can take this association forward. It's our dream to conduct an All India Ophthalmic Conference in Kollam, maybe in the long run, with the help of this young team and with advice from our seniors. Thank you.
Thank you, Madam. It's now time for the ceremonial lighting of the lamp. We request our chief guest, Dr. S.J. Sai Kumar sir, to inaugurate the ceremony by lighting the lamp. I invite Dr. Sai Kumar sir to deliver the inaugural address.
A very good morning to all the dignitaries assembled for this Ashtamudi Ophthalmica. All the persons sitting on the dais, we all know, I am not going to name them all over again. Respected Sushila Madam, Lifetime Achievement Award awardees Gopi sir and Balakrishnan sir. It's indeed a very pleasant, great morning to be here in Kollam today to officially inaugurate Ashtamudi Ophthalmica 2022 in the absence of our President Dr. Arup Chakravarti. when I think Dr. Nesa mentioned about the first award winner was R.D. Ravindran sir. So I suddenly remembered that was about 3 years back. Yeah, so that was probably before the pandemic. So it's about 2-3 years since this. But this is a very unique CME, annual CME program. All clubs have annual CME programs, most of them. But Ashtamudi Ophthalmica has stood out as a very unique program done by a very vibrant team in Kollam with very good dreams, like Dr. Mini said, of conducting an All India conference. It's not at all impossible, because all you need is a good venue. So if you have the venue in Kollam, I am sure you have the potential, the team, to easily conduct an All India conference. So the only thing probably that prevents you from conducting, and the only thing that Cochin has an edge over others, is the venue. So otherwise, I don't think the team in Kollam is in any way inferior to Cochin Ophthalmic Club or any other club in the state of Kerala. So I'm extremely happy to be here this morning to inaugurate Ashtamudi Ophthalmica. And I also would like to remind all of you that the annual conference of our KSOS is coming up in Calicut, 25th to 27th of November. So please attend the conference. It is your conference. Attend in large numbers, and a special invitation from my side, because I am taking over as president of the KSOS. So a very special invitation to all of you. So I won't take much time. I officially inaugurate the CME program. Both the sessions that have happened today morning were quite informative, very good, lot of audience participation, and I'm sure the other 2 sessions will also be good, and Rajiv has promised a musical program after that also. So we are looking forward to all those sessions and the program as well. Thank you very much. So officially inaugurate this program.
Thank you, sir, for your kind and encouraging words. Next, we are moving on to the important part of our inaugural ceremony, awarding the prestigious Dr. S. Mohandas Memorial Oration Award to Dr. Sushila B. Nair, Madam, taking into account of all her excellent activities over the whole career. May I request Dr. Mini Jayachandra, Madam, to adorn Dr. Sushila, Madam, with Ponada and present the plaque to her. I invite Dr. Sushila B. Nair, Madam, to the dais. Sushila Madam will be introduced in detail during oration. Thank you, Sushila Madam.
The plaque reads as, Kollam Ophthalmic Association has immense pleasure in bestowing the Dr. S. Mohandas Memorial Second Oration 2022 on Dr. Sushila B. Nair in appreciation and acknowledgement of her dedicated and distinguished service in clinical ophthalmology and ophthalmic education. Her contribution to our society in various capacities is deeply appreciated. Presented on the 16th day of October 2022 during Ashtamudi Ophthalmica, the annual conference of the association at Kollam, signed by the President and Secretary of Kollam Ophthalmic Association.
Once again, thank you, Sushila ma'am.
Next is honoring Lifetime Achievement Award to Dr. K.S. Gobinathan Nair sir and Dr. K. Balakrishnan sir for their dedication in the field of ophthalmology. Dr. K.S. Gobinathan Nair, sir, he did his MBBS from Government Medical College, Trivandrum, DOMS from Nehru Institute of Ophthalmology and Research, Sitapur, and MS from Government Medical College, Trivandrum. He then joined Kerala Health Service in 1972 and retired after 27 years of tireless service. He is married to Dr. Vasantakumari Amma, gynecologist, and they are blessed with two daughters, Dr. Deepthi V. Gobinath, Assistant Professor in Dermatology, and Dr. Divya V. Gobinath, IPS. Dr. Balakrishnan, sir, he did his MBBS from Trivandrum Medical College and DO and MS from Calicut Medical College. He joined Kerala Health Services in 1970 and retired after many years of experience. He is married to Meera Ben, and they are blessed with 3 children. May I request Dr. Gobinathan Nair, sir, and Dr. Balakrishnan, sir, to come to the dais. Now, may I request our chief guest, Dr. Sai Kumar, sir, to adorn them with the ponnada and to hand over the plaque.
This Lifetime Achievement plaque reads, Lifetime Achievement Award presented to Dr. K.S. Gobinathan Nair in appreciation and acknowledgement of his dedicated and distinguished service in ophthalmic practice. His contribution to our society in various capacities is deeply appreciated. Presented on this, the 16th day of October 2022 during our Ashtamudi Ophthalmica, the annual conference of the association at Kollam, signed by Dr. Mini and Dr. Shaini.
Thank you, Sai Kumar, sir. May I request Dr. Sai Kumar, sir, to adorn Dr. Balakrishnan, sir, with ponnada and hand over the plaque.
Lifetime Achievement Award presented to Dr. K. Balakrishnan in appreciation and acknowledgement of his dedicated and distinguished service in ophthalmic practice. His contribution to our society in various capacities is deeply appreciated. Presented on this, the 16th day of October 2022 during Ashtamudi Ophthalmica, the annual conference of the association at Kollam, signed by Dr. Mini and Dr. Shaini.
Thank you, Dr. Sai Kumar, sir. Now, may I request Dr. K.S. Gobinathan Nair, sir, to speak a few words.
എല്ലാവർക്കും ആദ്യമായി ഒരു വാം ഊപ്പുകയാണ് തരുന്നത്. സാധാരണയായിട്ട് ഇങ്ങനെ അവാർഡുകളൊക്കെ കൊടുക്കുമ്പോൾ അവിടെ 2 മിനിറ്റൊന്നും കൊടുക്കാറില്ല ഒരു എന്തെങ്കിലും പറയണമെന്ന്. എനിക്ക് തോന്നുന്നത് കൊല്ലം ഒഫ്താൽമിക് ക്ലബ്ബ് തുടങ്ങിയ സമയം മുതൽ അതിൽ പല രീതിയിൽ പങ്കെടുക്കുകയും ഭാഗഭാക്കാകുകയും ചെയ്തുകൊണ്ട് ഡോക്ടർ രാജീവ് സുകുമാരനും ഡോക്ടർ അനീഷ് മാധവനൊക്കെ വിചാരിച്ച് കാണും അന്ന് മുതലുള്ള ആൾക്കാരല്ലേ ഒരു 2 മിനിറ്റ് കൊടുത്തു കളയാമെന്ന് വിചാരിച്ച് കാണും. അതാണോ ഇനി അതല്ല, അവരെ വന്നതല്ലേ അവരുടെ വല്ല ഒരു സദസ്സിനെ ഒന്ന് അഭിമുഖീകരിക്കുമ്പം എന്തെങ്കിലും ഒരു ഉപദേശം വല്ലതും പ്രായമായതുകൊണ്ട് കൊടുത്തതാണോ എന്ന് ആയിക്കോട്ടെ എന്ന് വിചാരിച്ച് കാണും. ഇതൊന്നുമല്ല എങ്കിൽ ഞാൻ ഉദ്ദേശിച്ചു വയസ്സന്മാരല്ലേ അവരുടെ വാക്വിലാസങ്ങളൊക്കെ ഒന്ന് കേട്ട് കഴിഞ്ഞാൽ ഒരു പക്ഷേ അത് എങ്ങനെ ആയിരിക്കും എന്നുള്ള ഒരു കുതന്ത്രമായ ബുദ്ധി ഇതിന് പുറകിൽ ഉണ്ടാകാൻ യാതൊരു തരവുമില്ല. എന്താണ് എനിക്ക് നന്നായി അറിയാം അവരുടെ അസോസിയേഷനുമായിട്ടുള്ള ബന്ധങ്ങളും അവരുടെ മാനസികമായ അവരുടെ രീതികളും. അതുകൊണ്ട് അങ്ങനെ വിചാരിക്കാൻ യാതൊരു തരവുമില്ല. എനിക്ക് തോന്നുന്ന ഒരു പക്ഷേ നമ്മുടെ KOA എന്ന് പറയുന്നതായിരിക്കും ആദ്യത്തെ ഡിസ്ട്രിക്ട് അസോസിയേഷൻ എന്ന് ആണ് എൻ്റെ ഓർമ്മ. അതിന് ഇത്തരുണത്തിൽ ഡോക്ടർ S. മോഹൻദാസിനെ ഞങ്ങൾക്ക് സ്മരിക്കാതിരിക്കാൻ ഓർക്കത്തില്ല. അതെന്തുമാകട്ടെ, അങ്ങനെ തുടക്കത്തിൽ മുതൽ എല്ലാ കാര്യങ്ങളിലും ഈ കുറഞ്ഞൊരു സമയം വരെ അതിൽ പങ്കെടുക്കാൻ സാധിച്ചതിൽ ഞാൻ ഇന്നും വളരെ കൃതാർത്ഥനാണ്. ഇതുകൂടാതെ അസോസിയേഷനിൽ നമ്മുടെ സ്റ്റേറ്റ് ലെവലിലും പല കാര്യങ്ങളിലും പങ്കെടുക്കാൻ സാധിച്ചിട്ടുണ്ട്. പിന്നെ ഉപദേശങ്ങളെന്നൊക്കെ പറഞ്ഞത് ഉപദേശം അവിടെ നിൽക്കട്ടെ. അടുത്തതായിട്ട് ഞാൻ ഈ സദസ്സിനെ അഭിമുഖീകരിക്കുമ്പോൾ ഞാൻ കാണുന്നത് മേരി കുര്യാക്കോസ് മാഡവും ഡോക്ടർ സുശീല B. നായരും ഒക്കെ എൻ്റെ ടീച്ചറും, അതിൽ ഒരു അതുകൂടാതെ ഒരു നല്ല ശതമാനം കൂടെ അന്നത്തെ സമയത്ത് വർക്ക് ചെയ്തവരും സഹപാഠികളും ആയിട്ടുള്ളവരും, അതിനുപരി അതിലും പുറകിലേക്ക് കാണുന്ന കുറേ ആൾക്കാർ, അതായത് ഞങ്ങൾ നടന്നു വന്ന വഴി വളരെ ഗംഭീരമായിട്ട് അഭിനയിച്ചും പ്രവർത്തിച്ചും വന്നുകൊണ്ടിരിക്കുന്നവരാണ്. അപ്പോൾ അതുകൊണ്ട് ഇതിലേക്ക് ഒരു എക്സ്പ്ലനേഷനൊന്നും തരാൻ ഞാൻ ഉദ്ദേശിക്കുന്നില്ല. പക്ഷേ ഒരു കാര്യം എനിക്ക് എപ്പോഴും ഓർമ്മയുണ്ട്. ഡോക്ടർ സുജിയ B. നായർ, അതായത് റിട്ടയേർഡ് പ്രൊഫസർ, എപ്പോഴും എന്നെ കാണുമ്പം ഗോപി സാറേ എന്ന് വിളിക്കും. അപ്പം ഞാൻ ഉദ്ദേശിച്ചാൽ എന്തോ എന്നെ ഈ ഗോപി സാറേ എന്ന് വിളിക്കുന്നത്. പിന്നെ ഒടുവിൽ ഞാനിങ്ങനെ കുറേ ആലോചിച്ച് കഴിഞ്ഞപ്പോഴാണ് എനിക്ക് പിടികിട്ടിയ അദ്ദേഹം എൻ്റെ ടീച്ചറും ഞാൻ അദ്ദേഹത്തിൻ്റെ സ്റ്റുഡൻറ്റും ആയതുകൊണ്ടായിരിക്കും എന്നെ അങ്ങനെ വിളിക്കുന്നതാണ്. അങ്ങനെ ആ ഒരു കാര്യത്തിൽ ഞാനിപ്പം വളരെ കൃതാർത്ഥനാണ്. പക്ഷേ അതോടൊപ്പം എന്നോടുള്ള ആ നല്ല മനസ്ഥിതിക്കും ആ പെരുമാറ്റത്തിനും ഞാൻ അതീവ കൃതാർത്ഥനുമാണ്. പിന്നെ അടുത്തത് പറയുന്നത്, ഈ ഉപദേശങ്ങളെപ്പറ്റി പറഞ്ഞപ്പം ഞാൻ ആലോചിക്കുകയായിരുന്നു, 45 വർഷം മുമ്പ് ഉണ്ടായിരുന്ന കണ്ണുവൈദ്യവും ഇന്നത്തെ കണ്ണുവൈദ്യവും കൂടെ നമ്മൾ കമ്പയർ ചെയ്യുമ്പം ഇന്നത്തെ വിദ്യാഭ്യാസത്തിൻ്റെ ഗഹനവും ആഴവും ഒന്നും ഇല്ലാതിരുന്ന സമയത്ത് ഞങ്ങളെപ്പോലുള്ളവരെ വന്ന് അതിൽ കുറേ പേരിപ്പം പിന്നെയും അതിലും മിടുക്കരായിട്ട് പോകുന്നുണ്ട്. സായികുമാറൊക്കെ അതിൻ്റെ ഒരു ഏറ്റവും വലിയ, വയസ്സായില്ലെങ്കിലും അതായത് പ്രൊഫഷണലി മുൻപന്തിയിൽ നിൽക്കാൻ സാധിച്ചു. പക്ഷേ ഇന്നത്തെ യങ്സ്റ്റേഴ്സ് അവർ ഇതെല്ലാം കഴിഞ്ഞ് അതിൻ്റെ എല്ലാം എത്രയോ പടി മുമ്പോട്ട് വന്നിരിക്കുന്നു. അതിന് ഞാൻ അവരെ കൺഗ്രാജുലേറ്റ് ചെയ്യുകയാണ്. പിന്നെ കൂടുതലായിട്ട് ഞാനൊന്നും പറയാൻ ഉദ്ദേശിക്കുന്നില്ല. ഇതിന് എനിക്ക് ഒരു അവസരം തന്നതിന് KOAയും സ്റ്റേറ്റ് ഒഫ്താൽമിക് അസോസിയേഷനെ KSOSനെയും പിന്നെ ഇവിടെ കൂടിയിരുന്ന നിങ്ങൾക്കെല്ലാവർക്കും എൻ്റെ കൂപ്പുകൈ നമോവാകും.
Thank you, sir. May I request Dr. K. Balakrishnan, sir, to speak a few words.
എല്ലാവർക്കും എനിക്ക് കൂടുതലൊന്നും സംസാരിക്കാനുള്ള കാരണം ഗോപി സാറിന് തന്നെയാണ്. ഗോപി സാർ എൻ്റെ ലീഡ് എനിക്ക് മുമ്പേ സഞ്ചരിക്കുന്ന ആളാണ്. അദ്ദേഹം തന്നെ എല്ലാം എനിക്ക് പറയാനുള്ളതും കൂടി പറഞ്ഞിട്ടുണ്ട്. എങ്കിലും ഞാൻ 42 വർഷമായിട്ട് ഒഫ്താൽമോളജിസ്റ്റായിട്ട് പ്രാക്ടീസ് ചെയ്യുന്നുണ്ട്. അന്ന് മുതൽ ഇന്ന് വരെ എല്ലാ സഹപ്രവർത്തകരും എനിക്ക് വേണ്ട എല്ലാ സഹായങ്ങളും ചെയ്തു തന്നിട്ടുണ്ട്. അതിന് ഇത്തരുണത്തിൽ ഞാൻ നന്ദി പറഞ്ഞുകൊണ്ട് അവസാനിപ്പിക്കുന്നു. താങ്ക് യു.
Thank you, sir, for your words of wisdom.
We request Dr. Shaini Napoleon Madam to felicitate the gathering.
Good morning to all. Respected Chief Guest and President-elect KSOS Dr. Sai Kumar, KOA President Dr. Mini J, Organizing Chairman Dr. Nisa, Organizing Secretary Dr. Divya, S. Mohandas Memorial Oration Awardee Dr. Sushila B. Nair, Lifetime Achievement Award winners Dr. Balakrishnan sir and Gobinathan sir, respected seniors and dear friends. Kollam Ophthalmic Association is really blessed with well-experienced and supportive seniors like Rajiv sir, always supported by Jayasree madam, JP sir, Rameshan sir, then Uma ma'am, all are there. And also it is blessed with energetic and enthusiastic juniors like especially I have to say about Divya, the organizing secretary, who has very well organized this meeting and very well supported by Nisa ma'am and Mini ma'am and all other juniors. Unity is our strength and it is evident here. Proud to be a member of this association. Here today we are conducting our annual CME, Ashtamudi Ophthalmica 2022, a case-based discussion under the aegis of KSOS, and it is enriched with knowledge, fun and entertainment. Hope all of you will like it and expecting a wholehearted participation for the success of the CME. Thank you.
Thank you, ma'am. I invite Dr. Divya Kishan to deliver the vote of thanks.
Good morning, everybody. Ashtamudi Ophthalmica is the pride of Kollam Ophthalmic Association, and it is my proud privilege today to propose the vote of thanks in this 6th annual meet. First of all, let me thank the Almighty for making this vibrant in-person meet possible after so many months of COVID gloom. Let me extend my sincere thanks to KSOI's President-elect, Dr. S.J. Sai Kumar sir, the Senior Consultant of Cataract and Glaucoma Services at Giridhar Eye Hospital, for accepting our invitation and coming over here today to inaugurate the ceremony. Thank you so much, sir. Dr. Sushila B. Nair madam is a teacher of teachers and has been a mentor of hundreds of ophthalmologists. We are proud today to bestow the Dr. S. Mohandas Memorial Oration Award to you, madam. Thank you for coming. Kollam Ophthalmic Association is now under the dynamic leadership of Dr. Mini Jayachandran, the President of Kollam Ophthalmic Association. I extend my sincere thanks to you, madam, for all the help you have extended for the CME. I would also like to thank Dr. A. Nisa, the organizing chairman of Ashtamudi Ophthalmica, for efficiently organizing the CME. Thank you, madam. Let me also extend my sincere thanks to Dr. Shaini Napoleon, the Secretary of Kollam Ophthalmic Association, for her meticulous planning and implementation and all her help extended in conducting the CME. Thank you so much. The veteran Kollam Ophthalmic Association members, Dr. K. Balakrishnan and Dr. K. S. Gobinathan Nair sir, are a role model to we the youngsters. Thank you for coming over and accepting a token of appreciation. Thank you so much. I would be really failing in my duty if I do not acknowledge the efforts put in by our dear KOA members, especially Rajiv Sugumaran sir, who has worked tirelessly behind the scenes for organizing each and everything about the CME. Dr. Jayaprasad sir, Jayasree madam, Dr. Vishnu, Dr. Uma madam, all senior KOA members, and my dear friends who were energetically behind everything about the CME. Thank you so much. The time and effort put in by our faculties, the chairpersons, conveners, lead, and panelists for organizing this academic feast requires a special mention. Thank you for the efforts that you have put in for this academic feast. On behalf of the Kollam Ophthalmic Association, I would also like to extend my thanks to Mr. Naufel, the event coordinator, the trade companies Appasamy, Endode, Microvision, Sunways, Sun Avesta, Astrax, Alcon, Sun Milmet, Chetana, Cipla, Zivira, Agenda, Rhines, Java, all who have contributed to the CME. Zivira, Mr. Anish and Vivek for the travel arrangements, the audiovisual team, and this hotel management for these effective organizations. Last but not the least, thank you, dear delegates, my teachers, my seniors, my colleagues, my postgraduate students who have accepted our invitation and have come here. Your presence here mean a lot. Thank you so much.
Thank you, ma'am. Now we came to the conclusion of inaugural session. Thank you, dignitaries on the dais. Now we move on to the most awaited session, oration by Dr. Sushila B. Nair, Madam. To chair the session, I invite Dr. P.S. Girijadevi, Ma'am, former Director, RIU Trivandrum, and Dr. Divya Kishan to moderate the session.
Thank you, Kollam Ophthalmic Club, for giving me the opportunity to chair this session where Dr. Sushila B. Nair Madam is giving the keynote address. My association with Dr. Sushila B. Nair Madam lasts for 4 decades. I met her first when she was joined the RIU as assistant professor and I was a PG there. After that, she has been closely associated with me for several years as my teacher, then as my senior faculty, senior unit chief, then as the director and superint, and even after that we have a very warm and cordial relationship. She is a great teacher, a great physician and surgeon, and a role model for all ophthalmologists, and Divya will give a detailed CV of her.
Thank you, Girija ma'am.
Dr. Sushila B. Nair Madam, after completing her MBBS, MS and DO from Kerala University, started her illustrious career as tutor in Government Medical College, Alappuzha in the year 1976. She has worked in various government medical colleges of Kerala as assistant professor, associate professor and professor, and she retired from government service as director and professor of ophthalmology in 2004. In May 2004, she joined as professor and head of the department of CSI Medical College, Karakonam, and continued as professor emeritus of the same college till 2016. Presently, she is working as honorary senior consultant in ophthalmology in KIMS Hospital, Trivandrum. During the span of 45 years, apart from clinical work, she has taught undergraduates and postgraduate students, supervised the thesis works and research papers, and was a guide, co-guide, and did a lot of eye surgeries and presented various conferences. And her areas of special interest were cataract and anterior segment surgery, squint, and oculoplasty. She has also organized, conducted, and took part in various CME programs, including being the organizing secretary of midterm and annual conferences of Kerala Society of Ophthalmologists, chaired annual CME programs of RIU Trivandrum, organized a national level surgical workshop at RIU for 1 week with experts from AIMS Delhi, and she has conducted CME programs with other departments of Medical Colleges Trivandrum and District Ophthalmic Rep. She was a past president of the RIU Alumni Association and presently the president of the Trivandrum Ophthalmic Club. She was also in the forefront of community services and has conducted numerous cataract screening camps, school screening camps, eye donation programs, and has worked as a co-chairperson in Sentinel Surveillance Program of the National Program of Control of Blindness. She has also held other positions like Member Scientific Committee of RCC Trivandrum, Member Academic Council of University of Kerala, and Honorary Consultant, Sri Chitra Institute of Medical Sciences, Trivandrum. Her awards include Henry Dunant Award for the International Red Cross Society in 2003, District Lions Club Excellence Award in 2012. Let me invite Madam for the Dr. S. Mohandas Memorial Oration. We are all ears to listen to you, Madam.
Thank you both for the very nice words. A very good morning to all of you. And it is always a pleasure to come to Kollam to attend Ashtamudi Ophthalmica. And I feel I have never missed one annual conference of yours. because of the hospitality, very nice people and very good ambience and the good presentations. But when Dr. Rajiv asked me to give an oration, I pondered for a while about what topic to choose from, and I consulted a person in front of me, Dr. Sahasranama, as to what topic to choose. And he also gave me some good advice. Then finally, I divided my oration into two parts. The first part, as my title says, I am going to take you all on a journey along with me for the period from 1973 to the present day, during which time I had the privilege and opportunity to see the evolution of cataract surgery in the state of Kerala. After the wonderful sessions which we had on cataract and glaucoma, now all of you sit back and relax and come on a journey with me from 1973. So my oration's second part is about a topic which I believe has been neglected, and it concerns our future generations also. And I thank Dr. Nisa, Dr. Rajiv, Dr. Mini, Dr. Divya, Dr. Shaini, Dr. Vishnu Mohan, and all the members of the Kollam Ophthalmic Club for asking me to be here this morning. Thank you all. So with that, we proceed. Okay. No, one slide I missed. Can you please help me, Versi? Just one slide I missed. This one. So before I start my oration, this is Dr. S. Mohandas, as if the new people may not know him. This is the person on whom I am here to say this oration. He was a very popular and well-known ophthalmologist and an active member of many organizations. And he and perhaps Uma Madam were the first to start an eye clinic in this area in the private sector. And in the 2012 alumni meet, we at RIO were fortunate to have him with us to receive a memento in the memento for his excellent contributions to ophthalmology, and my humble pranam before him. Before I start the oration, I want to working. This one is working and working. Yes. Click here. Forward back okay, that's it. So before I go to the topic of oration, I would like to just bow before these three people on the screen. The first is Dr. K.S. Subramaniam, who was my professor for all 3 years of my MS course. He was a very intelligent, very learnable, very learned and very well-known person in Trivandrum at that time. And he was a very good teacher for us, and everybody who got to know him wanted to respect him. Then the second person is Dr. T.A. Joseph, who was my professor in Kottayam while I was doing my undergraduate course, and later I had the opportunity to work with him in Trivandrum Medical College, in Trivandrum Government Ophthalmic Hospital. He was an excellent surgeon, a very fast surgeon, and he was really a comprehensive surgeon who could do, apart from cataract surgeries, he could do orbitotomies, penetrating keratoplastics, and strabismus surgery and what not. So we all respected him very much. The third is Dr. M.G. Krishnan, who was also our professor. He was a very good teacher, a very kind-hearted man, and he could do small incision cataract surgeries very well, so that after the surgery, if you put a +10 diopter lens in front of the eye with aphakia, the person used to read 6/6 at that time. No astigmatism. So my oration, as I told you before, it has two parts. One is the history of cataract surgery, and it mainly concerns my roadmap from 1973, and the plight of preterm babies who may have eye problems and need close follow-up. I really doubt whether we are neglecting at least some of these. We'll start from the history of cataract surgery, the early part. The earliest report about cataract surgery is from the 5th century BC. The surgery that was done was called couching, and the meaning of couching is to put to bed. It was done in Babylonia, Egypt and Japan, where usually the cataract will be a mature or a hypermature one. With pressure over the eyeball, the lens falls back into the vitreous and gives the person some vision. That was couching. In the 6th century BC in India, Kerala, Shushruta was the surgeon who did cataract surgery probably by couching, but he used a metal needle which was sterilized in the fire before doing the couching in pushing the lens back into the vitreous. We get a mention of cataract surgery like incident from the Holy Bible, Mark chapter 3 verse 4, where Jesus heals the blind man of Bethsaida. What the blind man described immediately after he got vision was, the man looked around. He said, I see people, but I can't see them very clearly. They look like trees walking around. This is the vision of uncorrected hypermetropia. The person probably got vision at that time. There was uncorrected hypermetropia. Bible says that again he placed his hands over the eyes and the patient should see clearly. So that is from Bible. I need some help with the trick. Okay. Now we continue the history. In Greece and Rome, couching was practiced. There is no authentic details in the text. Arabs also used syringe-like instruments to remove cataracts. Probably it was absorbed in Morgagrian cataract or something like that. Daviel did his first true extracapsular surgery with needle and scissors in Paris in 1748. Modern cataract surgery gradually evolved from 1860 when Bongrevie's cataract knife was introduced. In 1884, they started using anesthesia for cataract surgery. Before that, the hands and the feet were tied while doing the procedure of cataract. In 1884, cocaine anesthesia came. In 1949, there was a huge transformation in surgery when Harold Ridley developed the first intraocular lens. It was probably a failure, but later on, various varieties of intraocular lens came. In 1950, operating microscopes were introduced into eye surgeries. And in 1967, Charles Kellman brought in phacoemulsification. In 2010, femtosecond laser was introduced for cataract surgery. Newer intraocular lenses, multifocals, toric IOLs came in as further improvements. In this, there is an interesting story which probably some of the seniors might remember. There was a doctor called M.C. Modi who was an Ayurvedic doctor who traveled all over India and conducted cataract surgery in camps. During the period from 1950 to 1960, he did more than 50 million people. More than 50 million cataract surgeries were operated by this person, and he was awarded Padma Shri by the government of India. We do not know what type of surgery he did. Dr. Modi was perhaps the first person to conduct eye camps for cataract surgery in India. Now we start my journey. It was in September 1973 that I joined for MS at RIO, the then Government Ophthalmic Hospital, Trivandrum. Little did I realize then that I was stepping into an institution with a very long history, a history of more than 70 years at that time probably, because it was started in 1905, and an eminent galaxy of eye surgeons worked there, and it was an institution which had history was sleeping there. I didn't understand all this about the eye hospital when I stepped into the institution. And also, neither did I realize that this place was to be my breadwinner, or I was to work there for almost a period of 20 to 26 years. And it was an extended family for me. All these people from RIO are my family members from the same day till today. And as long as I am there, it will be there. I forgot to mention something more about my teachers. I had more the pictures I show. Along with that, I had a host of other teachers whom I keep with deep respect in my heart. And one of them is Mary Kuriakos Madam. I went and got her blessing, but I forgot to tell about her. And one thing which I adore about her is the way she deals with her patients. She's very patient and she's very caring to her patients, and that is one thing I think we all should learn from her. She's here in the crowd. Very pranams to Madam. She's my teacher at Kollam Medical College for my undergraduate days, and later I worked with her in Trivandrum. I just forgot, that's why. So, when I joined the hospital as a MS student, there were 4 MS students and 3 DO students admitted each year. Ducal volumes, Parsons textbooks, Sosby's text, Stellar's eye surgery, and some books on glaucoma constituted our reading material. There were 2 bookshelves in the professor's room where all these books were kept, and all PGs had free access to all the books, but they were not allowed to take away the books. All PGs managed OP work with the help of seniors, took duties and attended noon clinics where interesting cases and problem cases were discussed. I'm sorry, it's not working sometimes. I think I ക്ലിക്ക് ചെയ്യുമ്പോൾ അത് ശരിക്കും വരുന്നില്ല. നിങ്ങൾ വരുന്നുണ്ടോ? അത് തന്നെയാണ് നോക്കിയത്, വേറെ പോട്ടെ. ഇപ്പോൾ ബാക്കാണ് പോകുന്നത്. ഐ ആം ഗോയിങ് ബാക്ക്. ഫ്രണ്ട് ഇതെടുക്കുക, ഏതാണ് തിരിച്ചു വയ്ക്കാം. എനിക്കൊരു കീബോർഡുണ്ട്, കീബോർഡ് പ്രസ് ചെയ്യുമ്പോഴേ തിരിച്ച് മുമ്പോട്ടും പുറകോട്ടും ഒക്കെ പോകുന്നത്. ഓക്കെ, കുഴപ്പമില്ല, അത് തന്നെ കുഴപ്പമില്ല. And there was one slit lamp which was kept in the professor's room, and most of us were scared to ask for permission to use it. 90D lenses and 78D lenses were not there, but there was an attachment to the slit lamp which was called the ruby lens, with which the posterior segment could be seen. There were head loops which were used for magnification in the OPD and OT. One indirect ophthalmoscope was there. There were no CME programs, but the annual meeting of KSOS was there, and some examiners who came for examinations took classes for us. We were allowed to attend the CME programs by Aravind Eye Hospital, Madurai, which were very good. Regarding our surgeries for cataract, there was one OT for surgery with formalin fumigated with 2 tables, no microscopes. The light source was a 3-cell torch which was held by a PG while the surgeon was operating. And we had to hold the torch in the right position where the surgeon wanted the light to be. That you have to understand. There were no gloves. Initially when I joined, gloves were not in use, no switches. Viscoelastics were unheard of. Everything was under air, all procedures. Then pilocarpine, hometropin, drosine and atropine were the only drops available. Anything else? I forgot. The surgical procedure, retrobulbar block was used with all its complications. Now we never use it. What are the complications of retrobulbar block? Probably you might have even forgotten. Retrobulbar hemorrhage, injection into the sheath of the optic nerve, patient collapsing on the table, other complications were there. So they are all not there now. Intracapsular cataract recession was the choice surgery at that time. And what is done in intracapsular cataract recession is the Bart Parker knife is introduced through the 3 o'clock or 9 o'clock position. It passes through the entry chamber, comes out at the other end. Then with sawing movements, it comes out at the upper pole of the eye. Then with a small tip of conjunctiva above it, the knife comes out. And there is an iridectomy, if probably a peripheral iridectomy, or when not possible, a sector iridectomy like what we see in the picture. Then the removal of the lens is by pressure and counter pressure when we apply a lens hook at the 6 o'clock position, and counter pressure for counter pressure. Counter pressure, and then the removal is with the help of capsule forceps or erisifake, which uses a vacuum for removing the lens. No switches were put, and bilateral bandage after surgery for 3 days was usually done. And with the person with the bilateral bandage in the eyes, people sometimes became delirious because of the bandage and they don't see anything at all. And the complications after cataract surgery were many, like iris prolapse, chamber shallowing, then vitreous touch of the cornea. Thank you. Infections and inflammations, late glaucomas in aphakia, all these were the complications. The picture I have shown, some people may not even have seen that nowadays. So this was the picture after a sector iridectomy and aphakic eye. We may never sometimes see this after a trauma. തിരിച്ചല്ലേ എന്നോട് പറഞ്ഞു തന്നെ പോകുന്നില്ല ഇതിപ്പോൾ എങ്ങോട്ട് പോയി അതെന്താ അങ്ങനെ വരുന്നത് ഇത് ശരിയാക്കി താങ്ങിക്കുക വാട്ട് ഈസ് ഹാപ്പനിങ് നിങ്ങൾക്കൊരു പുതിയ പിള്ളേർക്ക് ശ്രദ്ധ ആ കണക്റ്റിങ് ശരിയാക്കാൻ പറയുന്നല്ലേ അതൊക്കെ കഴിഞ്ഞു എല്ലാം കഴിഞ്ഞു ഇത് പുറകോട്ട് പോയി നമ്മളിപ്പോൾ ഒത്തിരി ഇതെന്താ ഇത് ഓക്കെ അതിന് ഇതായിട്ടില്ല കുറച്ച് he says something wrong with the connectivity. They can change from there. Then it's okay because this is not working properly. That's why. Okay. That is it. So then, very soon after this initial surgical days, very soon further developments came. We started ECC, extracapsular cataract extraction, with 5 switches. The incision, which was upper half of full half of limbal incision up to all the upper half of cornea, became reduced to 9 to 11 degree incision with corneal scissors, which were either right and left scissors or a universal corneal scissor which can be used on both sides. And the sutures were first of 8-0, and then came the ECC with continuous sutures where we used 10-0 nylon sutures. That time a person who was a good surgeon had to do good suturing. If the suturing was good, the post-op astigmatism was much less and the surgery was considered to be a perfect surgery. Then came the intraocular lenses, ECC with rigid lenses. Then the drastic change in cataract surgery came with phacoemulsification with 5 mm rigid lenses first, and then we used foldable lenses, hydrophilic, hydrophoric, toric IOLs, multifocal IOLs, anterior chamber lenses, iris claw lenses, phakic IOLs, etc. And the list goes on like that. And at the same time, when phaco became popular, small incision surgery also came to compete with it. Probably more people were interested in small incision cataract surgery because it is a less expensive type of surgery, takes lesser time, and almost comparable results between the two. Micro incision cataract surgery also came. Then after 2010 we had femtolaser surgery. Anesthetic agents also changed a lot, from xylocaine with adrenaline, bupivacaine, then injections changed to peribulbar, subtenon, topical and intracameral, which you are all familiar now. Next please. Now what is the future of cataract surgery? Cataract surgery is still our breadwinner and will remain like that for a long time to come. So what is the future developments which are possible in cataract surgery? One is robotic cataract surgery. In 2021 it was successfully tested in pig eyes and would enter human trials very soon. The device uses a complete pre-operative OCT scan to construct a model of the eye and plan surgery. During surgery, partial OCT scans are used to monitor where the automated instrument is inside the eye to direct it to the lens and cortical material remaining in the capsule. A surgeon monitors the operation and can override the device if necessary. Potential advantages of automated surgery includes more complete removal of the nucleus and cortical material and reduced risk of capsular rupture by providing better visualization, as well as people like me have a sort of tremor while doing surgery, eliminating the surgeon's tremor in the hands and providing tactile feedback in a semi-automated systems. What is the advantage of robotic cataract surgery when it comes? Next slide, please. Artificial intelligence is another one that is coming into cataract surgery. In cataract surgery, artificial intelligence can be used to reduce the workload of the consultants. Especially in some areas, after the COVID cases, the number of cataracts is so much that there is nobody to go there and check and pick out the people for cataract surgery. In those cases, we can utilize artificial intelligence. Simultaneous diagnosis of anterior and posterior segment diseases is possible, so that most artificial intelligence models have made use of slit lamp and images and fundus photographs. It can also be used in diagnosing posterior capsular opacification after cataract surgery, and it predicts the progression of the PCO to an accuracy of about 87%. In pediatric cataracts especially, the decision to operate is dependent on the development of amblyopia due to deprivation of visual stimuli. Ability of the artificial intelligence algorithm in diagnosing and assessing postoperative lens proliferation or glaucoma has been identified. It can also predict those at risk of developing congenital cataracts. Intraocular lens formula, SRKT, Holiday, etc., which we are being used now, these may all be replaced by AI-based formulas, providing higher accuracy than the present ones. Kane formula, Pearl DGS formula, and Lattice formula may replace the present ones in future. A word about congenital cataracts. When I entered the hospital in 1973, sorry, one more slide about artificial intelligence. Yes, I think it is a previous slide. In pediatric cataracts, the decision to operate is that I think I have just told you now, Lattice formula. The future directions of artificial intelligence are in reducing the global burden of corneal diseases and cataracts. It is already being used in retinal and optic nerve pathologies, but the limitations of artificial intelligence is a large amount of clinical data which has to be standardized with the variabilities in anterior chamber depth, angles, width of light beam, and a large amount of data has to be collected before we come to a conclusion. Still, artificial intelligence telemedicine, 5G and 6G networks, quantum communication networks, all these are likely to form a healthcare revolution in the future. A word about congenital cataracts. In 1973, the surgery that was available for congenital cataracts was needling and curette evacuation. In needling, a incision needle, a sharp instrument will be passed into the eye, and the cataract will be cut into cruciate. In the anterior capsule will be cut, and later on, when the cortical matter comes, the fluffy matter comes into the anterior chamber, it will be aspirated with a lens curette. But this procedure had many complications. The child usually comes with secondary glaucoma, uveitis, etc. And the lens curette aspiration is never complete, with a thick posterior capsular opacification, leaving the child again blind. Then came the lens aspiration by an incision, and then we started using lens aspiration with IOL. This also had problems because we know in the young eyes there is the possible proliferation of posterior capsular opacification. The lens matter proliferates and produces dense posterior capsular opacification. Sometimes you may even see the intraocular lens put into the posterior chamber in the anterior chamber. So these things happen in simple aspiration with IOL. Now then we found out pars plana lensectomy, lens aspiration with posterior capsulorhexis and vitrectomy, and lens aspiration with optic capture of the IOL. These are better procedures, and we can even do an IOL replacement when the power has been different. At a younger age we have put the lens, and later on we find that there is a change in the IOL power. Lens replacements are also being done now. Now we go to the second part of my oration. This is an unmet need. And it is a significant problem worldwide. This is the one which I wanted to give more importance than my journey through cataract surgery. The rate of preterm births worldwide is 5% to 18%. And of the 15 million babies born prematurely globally, 1/5 are born in India. preterm babies and term babies who are unwell are now, we all know, they are all surviving at higher rates. The threshold viability. Usually we get 22 to 24 or 26 weeks old child. We can see what is the general ocular development at this time. The gross structure of the globe becomes recognizable at approximately 7 weeks. The structure of the globe, such as the uveal tract and sclera, are near to full development. Retinal development also, up to in 24 weeks of gestation, retinal mitosis ceases, but the retina has to grow and mature a lot until 3 weeks after the term birth of the child. Cornea, lens, retina and macula have to develop further after 24 weeks. Corneal flattening, increasing in diameter just before term. Lens alters in shape from elongated to spherical, and all these changes happen after 26 weeks. So just imagine a baby born at 24 or 26 weeks and becomes viable. So preterm babies are born with a high risk of refractive errors, reduced visual acuity, strabismus, color vision defects, reduced contrast sensitivity and visual field defects. So these are all the problems we have to face in preterm babies. Reduced visual acuity can be due to, we all know, retinopathy of prematurity, which our retina surgeons will explain to us. Refractive errors, neurological deficits sometimes, and strabismus and amblyopia. These are the common causes for reduced visual acuity in preterm children. Retinopathy of prematurity, in the newborn period they may develop retinopathy of prematurity which may be treated or which may not need treatment. The sequelae of ROP are many and may result in total blindness in both eyes. Several epidemiological studies conducted around the world report that severe visual disability can occur even in high resource settings. ROP causes an increase in all types of refractive errors in later life: myopia, hypermetropia, astigmatism and anisometropia. What is the refractive state of a term infant? We all know that the infant is slightly hypermetropic. Primary, it is an axial hypermetropia. Over a period of time, they all become emmetropic. And refractive errors are 4 times more common in the preterm child, that is 29.6% when compared to term babies, 77.8. Myopia and ROP in children who are born preterm. If there is no ROP, there is a low risk of myopia in later life. Mild ROP and no treatment was necessary, it is a moderate risk, but ROP which was treated, and especially with lasers, there is a high risk of myopia. So these are all things we have to keep in mind when you see a preterm child in the OPD, which we do not usually spend time on these people so much, I feel. So that is why I took this topic. There are the 3 types of myopia which are associated with premature birth are: one is physiological and temporary myopia, myopia without ROP, myopia induced by severe ROP. Now, how to follow up, what to look for in a child? No ROP, there is no history of ROP, but still preterm baby, you have to look for myopia. The level of risk is very low, so you can follow up the child at 2 years of age and annually thereafter. ROP, but no laser treatment was needed, then you may have, the child may have myopia, astigmatism or strabismus. There is a moderate risk, so you have to keep the child on follow-up every year and annually thereafter. ROP treated with lasers, as I told you, the myopia may be high, astigmatism, strabismus and cortical visual impairment may be there in these people because they may be born with low birth weight. Anisometropia. At 3 months of age, the retina surgeon finishes his work by 1 or 2 months, and after 3 months of age, every 3 to 4 months up to 2 years of age we have to follow up, then every 6 months up to 6 years and annually thereafter. Incidence of other refractive errors, there are so many studies with controls. In most of them, the incidence of myopia seems to be a little higher than the other refractive errors. Strabismus. Rates of strabismus in preterm children were shown to vary between 9.5% and 22%. The risk of developing strabismus was, what are the factors? 2.2 times higher in those with birth weight less than 2,500 grams compared to those with normal birth weight, and 3 times higher in those born before 34 weeks of gestation compared to those born at term.
The age of onset of strabismus in low birth weight children is variable. From the first few months of life to many years later, you may have to follow up for strabismus. The ratio of esotropia to exotropia is 1:1. So, in the low birth weight population, 12% of the strabismus cases were classified as near exotropia. The degree of misalignment can vary over time, and making the decision whether and when to operate difficult for the surgeon in children who are than when compared to children who are born at term. The increased incidence of strabismus in children born prematurely has been attributed to one ROP. The greater the severity of ROP, the higher the incidence of strabismus at 6 months of age. Increase in refractive errors in the follow-up and neurological impairment. This is again a study, epidemiology based, regarding the prevalence of strabismus in fully accommodated esotropia, convergence excess esotropia, different types of exotropia, etc. There is no difference in the number between esotropia and exotropia much. This is another study, a functional ophthalmic factors associated with extreme prematurity in young adults. This was tried in young adults who were born preterm with very low birth weight, and the conclusion that they got was visual problems usually persist into later adult life. Overall, worse monocular and binocular best corrected visual acuity, binocular contrast sensitivity, all these were tested, and they found that all these problems might continue to adult life. Reduced visual acuity. Overall, extremely low birth weight infants, less than 1000 grams, are more likely to have vision of less than 6/60 than those born at term. How to proceed now? At initial and follow-up visits, consider the following. Is the child developing normally? Does the child seem to have a normal vision? This is not the usual Snellen's chart, but the other Lea symbols, all those things, other charts that we have, has to be used in children. Is strabismus or nystagmus present? Does the retina look normal and healthy? Is there a significant refractive error? Are there any other eye problems such as cataract? In the ETROP trial, early treatment for ROP trial, 1.9% of eyes developed cataract by 6 months of age. The lens can also be damaged during intravitreal injections. Very small eyes and intravitreal injections, the capsule may be damaged. There can be severe anterior segment ischemia following laser for aggressive posterior retinopathy of prematurity, and that can also lead to cataract and other complications. Glaucoma. Another complication in premature children that we may see is glaucoma. Approximately 2% of ROP treated eyes develop glaucoma by the age of 6 years. And it is secondary to laser treatment. Neovascularization of the angle of the iris in untreated eyes may also, in advanced ROP, also may produce glaucoma in the child. Another important problem why the children don't see is due to cerebral visual impairment, which is a very difficult problem to treat. The definition for CVI or cerebral visual impairment is visual impairment without primary ocular pathology. You examine the eyes, you don't find anything. No opacities, retina also looks normal. Pupil may be reacting, but the child cannot see. This is the abnormality due to visual brain system posterior to the optic chiasma. Hypoxic, ischemic, inflammatory events that disturb the cerebral white matter development has been blamed for CVI. Very premature, very low birth infants are likely to suffer from CVI also. Incidence is 24% when compared to controls. What are the measures used to define CVI? It's a very large topic, time consuming, but I will just tell you a few points. A comprehensive assessment of visual function. There are 7 scales which have been made to find out if the child is having CVI. Activities like visual attention, visual fields, an object brought from the periphery to the center when the child, whether the child can see the object. Perception of movement around the child, visual search, guidance of movement, attention, crowded scenes, and recognition and navigation. These are the things which you can check in a child, and the higher the score and the what happens in CVI is the eyes may be seeing, but the brain does not recognize. So what to do for these children? It's very difficult to manage them, but there are various therapies available for them, at least to help them to continue in life. Visual stimulation therapy, with large contrasted high light reflective and moving objects with added sounds. If the ear is functioning normally, sounds the child will recognize. Art therapy, various objects of various sizes, glasses, other things that commonly they use, all these shapes are made familiar to them by touch, and that the child is asked to get familiar with them. Music therapy, everybody likes music, no? So music therapy calms the child, can help to deal with crisis and trauma, and can stimulate cognitive functioning. Occupational therapy promotes self-confidence and which helps in daily activities. Physical therapy helps to move about and touch their surroundings. This is a visual development milestone. I got it from the Aravind Eye Care System. At 3 months, the baby looks at the mother's face. 6 months should try to touch objects, picks objects directly at 9 months. Like that, up to 36 months, the child should draw pictures, normal child. So, routine screening is not currently carried out in many settings at present, and increasing awareness among parents and teachers of the increased risk of a premature child having eye problems. We have to bring it that, and encourage vision testing if they have concerns is important in all settings. Prompt treatment of strabismus and high refractive errors is required to prevent amblyopia in these children and to promote normal development. Spectacles present a simple and affordable method of treating most of the refractive errors associated with preterm births, but require fitting and long-term follow-up so that prescriptions can be changed. And as the child grows, and moreover, repairing and replacing broken or lost spectacles is also essential. Children with profound visual loss will also require assessment in low vision services, access to assistive devices, appropriate placement and support in schools to improve their independence and quality of life, and ensure a happy, productive childhood. Thank you all for the patient listening. Thank you.
Thank you, ma'am, for your insights and words of wisdom. That was really a delightful experience to hear your vast journey of experience through 50 years. Also for the thoughtful advice of taking care of preterm infants, especially for us younger generations. Keep inspiring generations ahead, madam. I invite Dr. Uma Mohandas, madam, to hand over memento to Dr. Sushila B. Nair, madam. I request Dr. Girija, madam, to conclude.
Thank you, Dr. Sushila madam, for that very informative talk. Because cataract surgery, now youngsters think it is only phacoemulsification. We older generation had gone through so many steps. Once we are a master on technique, then that technique becomes obsolete, and then we have to retrain for the another next step. Then that also become obsolete by the time we become experts in that. And I think the youngsters are also coming to for that same type of procedure in the future. If they think the phacoemulsification is done, it is all over, but now more things are coming in the way, and they have to keep on running to remain in the same spot. And coming to the ROP children, now more attention is given to the ROP immediately after the delivery, but no long-term follow-up is given. No advice is given to the parents that these children need a lifelong follow-up, and that point has to be stressed, and the youngsters has to focus on that also. Then coming to the CVI, now we see the eye is normal and send them to the neurologist. But neurologist is not the person who have to help them. It is the ophthalmologist and other paramedical personnel who can help these children better. I hope they all carry valuable information and take home messages from Sushila madam's talk. Thank you.
May I invite Dr. Venugopal sir to hand over the memento to Dr. Girija madam. Let me invite Dr. Verma sir to conduct a quiz with an exciting cash prize.
I don't have any slides to present because this is a spur of the moment question. Nobody from my generation or slightly younger need to attempt because they probably might. This is for the younger generation. How old are you? Wait. Let the younger generation have the first chance. There is one ophthalmic surgical instrument named after a Malayali doctor. What is that? That's suspense. Nobody from the junior side? Okay, Annie, go ahead. Oh, അല്ലല്ല അവർ ജൂനിയേഴ്സിൻ്റെ ചാൻസ് കഴിഞ്ഞു ഇനി പറഞ്ഞോളൂ. No, it's not. Nobody? അല്ല, ഒഫീഷ്യലായിട്ട് അങ്ങനെയൊന്നുമില്ല. ഡ്യൂക്ക് കട്ലറിലുള്ള ഇതാണ്. This clue is it's not being used commonly now. But then you should know it as a part of your GK. Unless you have a past, you don't have a future. Yeah. It's something used in cataract surgery or used to be used in cataract surgery. It's the iris repositor. It's named after Dr. Koman Nair, who was the superintendent of Madras Eye Hospital, now the Chennai RAO. I tried to get a photograph of him through some of the people who studied there, but unfortunately I couldn't. Thank you.
Thank you, sir. Now we move on to the third session of Ashtamudi Ophthalmica 2022, Oculoplasty. May I invite Chairman Dr. J. Anthony and Convener Dr. Arya AU to start the session.
Good morning, all. After those two wonderful sessions of case presentations on cataract and glaucoma, I would like to take your attention for a beautiful case series discussion on oculoplasty. So good morning, welcome to Ashtamudi Ophthalmica 2022 Session 3 Oculoplasty. The chairman for the session, I'm so happy to welcome my teacher, Dr. Anthony J. Sir. He has completed his medical education, MBBS diploma and MD from Government Medical College, Thiruvananthapuram, and joined medical college service as tutor in RAO Trivandrum, and has worked in various capacities as assistant professor, associate professor, and professor in Kottayam, Calicut, and Trivandrum medical colleges for a total of 24 years, and has worked as professor HOD Department of Ophthalmology, Sri Gogula Medical College, Thiruvananthapuram for 13 years. And he has more than 10 publications to his account, and has published a book named Basic Measurements in Ophthalmology, which helps improve the clinical skills in diagnosis as well as surgical precision. Welcome to the session, sir. Now coming to our eminent set of panelists, we have Dr. Anis Sridhar ma'am. She's Senior Consultant, Little Flower Institute, Angamali, and has completed MBBS from Thrissur Medical College and MS from Calicut Medical College. She's joined Little Flower Institute in 1996 and has worked in various capacities. She's been mentored in oculoplasty under Dr. Santosh Honavar at LVPA Eye Institute in 2002 and has started the first full-fledged prosthetic clinic in 2005 at Little Flower Institute. Now she's heading the oculoplasty and neuro-ophthalm unit at Little Flower Eye Institute. Welcome, ma'am. Now we have Dr. Marian Poli, ma'am. She is Senior Consultant, Giridhar Eye Institute, Cochin. She has done MS from Kerala University and DNB from NPE. She's completed 2-year clinical fellowship program in orbit oculoplasty trauma and reconstructive surgery at Shankara Netralaya, Chennai, and has completed fellowship in ocular oncology from the prestigious Wills Eye Institute, US, and has passed basic sciences assessment of IZO, and is receiver of multiple awards.
No. Okay. Don't play it now.
Welcome to the session, ma'am. Now we have the presenter for the session who needs no special introduction. I am so fortunate to be her student, Dr. Fairuz B. Manjindavida. Welcome, ma'am. She is specialist ophthalmic plastic surgery, orbit and ocular oncology, and she is the director cum founder, Horror Specialty Eye Care, also Bangalore. And she has completed MBBS from Government Medical College, Thrissur, and MS from Mysore Medical College, Karnataka. And fellowship has been completed from LV Prasad Eye Institute and the prestigious Wills Eye Hospital, Philadelphia. Observership in Shiley Eye Institute, Santiago, US. And she is a Vice President, Asia Pacific Ocular Oncology and Pathology, member Scientific Committee AOS, and Section Editor IJO, and is alumni APAO Leadership Development Program, and has received multiple awards and honors. Over to you, ma'am.
So we can start the session, ma'am? All right. Hi. Good morning to everyone. It's a pleasure and honor to be here. Thanks to JP sir, Arya, Mini ma'am, and the organizers of Ashtamudi Ophthalmic treat today. And so I'm going to present few cases, and we'll have a great interactive discussion over the cases over here. And we have our honored panelists, Dr. Annie and Dr. Marian Polly over here. So I'm Fairuz and I'm from Bangalore, working in Amardeep in Kollam as well. It's not moving, the slides are not moving. Can someone help, please? So these are particular cases which I have actually chosen, which would be useful for everyone, and many cases which has given good lessons in our clinical practice. We always learn from cases, and that's how we evolve as a practitioner as well. Okay, so I have no financial disclosures or interests, and these are my affiliations. So case number 1, all right? So this is a 44-year-old lady who complains of watering since 2019, all right? She presented to me in 2021, and she was referred for a failed endoscopic DCR, which was done elsewhere, all right? And the doctor wanted to know whether I would want to consider DCT. It was persistent watering, all right? Yeah, so this is the patient. Diagnosed dacryocystitis, you can find a swelling over here, and referred for failed DCR opinion. In fact, she has undergone a septoplasty also along with endoscopic DCR. So, well, ma'am, you want to take it, have a comment on it. If we can give the mic to the panelists, that will be really nice.
I would first consider, as it's a young patient, I would first consider trauma.
Yes,
as for trauma, after a failed this thing, or a rhinosporidiosis.
Right, yes, yes. Especially in Kerala and Tamil Nadu, rhinosporidiosis is something that we would want to keep in mind. Sir, any comment from your side?
So this is a good occasion to talk and discuss about rhinosporidiosis, because this is a slowly forgotten topic.
Right.
When we were PGs and staff members, we used to do a lot of DCT for rhinosporidiosis and other ocular manifestations of rhinosporidiosis.
Yes, sir.
But now it is slowly going away from the new ophthalmology. This CME is a real creative CME. I am not. So this is an occasion to discuss about this slowly forgotten rhinosporidiosis.
Right.
What is the management? What is the incidence now? How much it is being affected? Please give all the information to the new ophthalmologist, because the case comes to them. I don't know how they are managing. Many of them are unaware of that.
Right.
If you can talk a little about from your experience, it will be very valuable and add to the success of this issue.
Sure, sure, sir.
Yeah, I would like to know, any palpable mass, syringing findings, RO+.
Great. Yes. So there is this. So we will get into that once we discuss the case. We will throw a brief highlight on rhinosporidiosis. So this is a mass that we see over here, and it was a kind of a firm mass which was palpable, around 8 millimeters in diameter. Well, it was not tender. All right, yeah. And what would you can actually see here, it's getting more evident over here. As Dr. Marian told, what is the next step would be definitely doing a Roplas, right? And it has been referred as a case of
failed endoscopy.
dacrocystitis. Well, Roplas is negative. Roplas is negative, the mass is firm. What would we do next is?
Syringing.
Syringing, perfect. And this is what the syringing shows. So, well, there is regurgitation, but there is regurgitation of a bloody discharge. Absolute block. The patient doesn't feel any water inside the eye. 100% regurgitation, and there were blood spots, which was regurgitating out in the fluid. Anyone from the audience can contribute. What would you do next? Ma'am, would you want to navigate?
I would like to take a CT because then we have to think again rhinosporidiosis and again mass.
Right, yeah. So, well, I have that for you. So this is what the patient already had actually, the MRI, and this is what the lesion looks. This doesn't look like a sac enlargement, right? It's very triradiate, and this was the DCR which was done earlier. So it's extending into the nasal cavity also. All right, you can see here. So this is the sinus, so the nasal cavity, and this is a large mass sitting there in a young 44-year-old. Now what do you do? So what are the differential diagnoses that you would think at this point of time? Ma'am, would you think this as a rhinosporidiosis? Ma'am, so there is a hole where the DCR has been done earlier. Okay. So that portion of the medial wall is missing. I have not put the CT scan. I did have the CT scan picture. This was much more clearer. So yes, there is a bony defect because of the previous DCR which has been done. Right.
But I think in masses you can get syringing free also, no?
Yes.
So
if it is a compressing mass over the sac, right, yeah. So ma'am is very, very right. If you have any neoplasms or anything which is sitting in and around the sac, one, it could arise from the sac. Second, it could be a mass lesion which is compressing the sac, which is over the sac and compressing the sac, where the patient will present with watering, and they will have a very typical presentation like a dacrocystitis and a primary nasolacrimal duct obstruction. So what would you want to do at this point of time? What are the differential diagnoses? Rhinosporidiosis. Anything else the audience want to contribute? Or yeah, Marian, please go ahead.
No, I consider it as some mass arising from the lacrimal sac.
Right. In your experience, what are the things that you have come across, Marian?
Most commonly it is lymphoma.
Okay.
So I prefer to do an incisional biopsy now.
Okay. All right. So yes. So what I did was I went ahead doing an excision biopsy. All right. Because whatever the lesion is, it is a very well-defined lesion. If something is very diffuse in the orbit, well, incision biopsy is the right way to go ahead. But when you're suspecting there is a high suspicion of a neoplasm, a malignancy, of course it's not a benign thing. It's a bloody discharge, something which is really growing large. With a well-defined lesion, you can always go and excise the whole thing, because the better the surgical clearance, the better the outcome for the patient in the long term. All right? Yeah, so I went ahead doing an excision biopsy in this, and this is what it came out as. So what is glaring here in this pathology slides? I'm sure not many would want to read a pathology slide, but this is very, very, you can see these small blue round cells, and there are some large blue cells also. So it's completely blue. Something which is completely blue is lymphocytes. Lots of lymphocytes. Lots of histiocytes. So this is what the slide looks like. And in your practice, ma'am, how has the histopathology evolved now? Like, it is just the basic histopathology, or this is what you do with the pathologist, right? It has changed.
Yeah, now the pathology has grossly changed. Now everything they will do immunohistochemistry.
Right, right. So there is no diagnosis in ocular pathology without immunohistochemistry now. So all of you who take out tumors, make sure that the appropriate immunohistochemistry is done, because there are different types of tumors. Some can simulate the benign lesion. So lymphoma is again a lymphoproliferative disease. It can be reactive lymphoid hyperplasia, lymphoproliferative lesion, or it could be lymphoma, which is a malignant extreme of a lymphoproliferative tumor. So this is the panel of IHCs that the specimen will go through. As you can see here, well, I can't count it, but there is so many number of immunohistochemistry which is done. CD45, CD20, BCL6 positive, CD20 positive, BCL6 positive, all these things are and these are the negative ones. So with this, it was diagnosed as diffuse large B cell lymphoma. And ma'am, diffuse large B cell lymphoma, it's like the high grade one, right? Anything, have you come across in your practice, ma'am?
Yeah, yes.
Marine, yeah.
Actually, patient come for routine DCR.
Right.
When you intraoperatively the sac is abnormally thickened, or
Right.
the color of the sac is usually pink, it is mucosa, no?
Right.
Most of the time when it's infiltrated with the tumors, it looks little white, like more towards whitish side rather than pink side.
Right.
So in that case, we do biopsy intraop.
Right.
And we had 2-3 cases turned out to be lymphoma.
Right.
To my surprise, to be frank.
Okay, and
Yeah.
were they all diffuse large B
One
cell or?
was diffuse large B cell,
Okay.
other was follicle cell.
Follicular, yeah,
lymphoma.
yeah. So I have actually operated a case at Amardeep also, which came out to be an extra marginal zone lymphoma. Typical. She was actually referred for DCR to me, and she had a mass lesion, suspicious firm mass rather than kind of a cystic dacryocystitis mass, and then it turned out to be an extra nodal marginal zone lymphoma. Yeah. So this was a case of diffuse large B cell lymphoma where the patient presented as acute dacryocystitis with a lacrimal sac mass. So these are the different types of lymphoma which we see. Most commonly, it is the extranodal marginal zone lymphoma, the low grade, and diffuse large B cell is very, very rare, and it is the high grade lymphoma, which comprise of 3%. So yeah, this is what we do as the next stage. So the treatment doesn't stop there, and the treatment doesn't get started until you do a PET scan. PET scan is a positron emission tomography where you scan the entire body, where you inject a dye and you find out whether there is any other foci in the body with a systemic involvement. And ma'am, this was the PET scan, right? Like there was no systemic involvement. So now we are thinking of anything treatment which has to be localized. So localized, what we do is, what would you prefer, ma'am, in this particular case, like treatment-wise? Well, a medical oncologist always is there in the team, but we will discuss between us also. Yes.
Radiation to the orbit.
Radiation to the orb.
How was the bone? When you did the surgery? Was it extending into the
Ma'am, I
ENT?
took the biopsy of the bone also. So I cleared that area. I took the biopsy of the bone, and the bone biopsy was also sent, which came negative. In fact, yeah, it was not infiltrated. Yeah, the bone was not
It was
infiltrated.
extending into the nasal cavities.
Yes, but
Because
the
already-
entire thing was excised. So when the PET scan was done, there was no residual in the localized area at all. There was no tumor
Nothing
residual.
to radiate.
Ma'am?
Nothing to radiate.
Right, actually there
Yeah.
is nothing to radiate, and it's a very large high grade tumor, right? Yeah. So in that situation, well, with the consultation of a hemato-oncologist, the patient went ahead, we always do the clinical staging. Staging system is very, very important. Even in our normal clinical practice, this is how we go through. The TNM staging is so important. So this is how we stage it. Ann Arbor classification is normally done for systemic lymphoma as well. So the hemato-oncologist, in discussion with the tumor board, decided to go for systemic chemotherapy. And actually the radiation, there was a plus or minus discussion about radiation. But since there was no localized disease at all, radiologically and PET scan, that was denied. And obviously the patient didn't want it also from her side, So the patient was treated with systemic chemotherapy, and now she is doing fine. But well, having a high-grade tumor, so the follow-up is so very important. It has just been 1.5 years of follow-up she's on. She's doing absolutely fine with no recurrence at this point of time.
So, what I wanted to ask, if an endoscopic DCR had not been done,
Ma'am.
and you're finding a mass in the sac, then what will you do? Like,
Yes, to the audience, the question to the audience, yeah. If you find a mass in the lacrimal sac, a DCR has not been done, what would you do? Everyone does DCR. I'm sure everyone in the audience does DCR, right? No, sir? Yeah, okay. So you once did, no? Once upon a time? Once upon a time, right. What would you do if you find a mass? Arya, you want to initiate and yeah.
What will you do if you find a mass in the sac? Yeah, you can take out the
Sac,
mass and-
right, yeah. So when on the table, if you go inside and if you're surprised that this is not what I thought and this has turned out to be like this, DCT, it's easy, right? Yeah, and go for a kind of a margin clearance also all around. If at all there is a suspicion, and send it to a nice pathologist, get all the immunohistochemistry done. So the other lesions that can arise, which I kept in mind in her case, my first differential diagnosis was a mucoepidermoid carcinoma of the lacrimal sac, because that is a glandular carcinoma, and that was first in my list when I did my differential diagnosis. Lymphoma was just second in my list, but it came out to be a very high grade lymphoma. Yeah. So yeah, can we go to the second case? Any comments from the audience? Yes, sir. Yes, sir. So the chance of systemic lymphoma in such high-grade tumors is around 30 to 40%, in fact. And even developing a systemic lymphoma later also, there is a high chance. So these patients undergo PET scan. Initially, in the first 1 year, every 3 months we do the PET scan, just to rule out any new lesions coming up in the body. Next 2 years, it will be a 6-monthly PET scan. Then after that, it's a yearly, definitely a systemic evaluation and follow-up goes on, yeah. So she can recur, she can develop. Now it's localized, but if there is any micro metastasis which is roaming around, she can develop a systemic lymphoma, and it's very high grade. So yeah, and she's young, her lifespan is long, right?
Do you see rhinosporidiosis there?
Now we'll just get to rhinosporidiosis, ma'am. Yeah. Yes, I have not seen lacrimal sac rhinosporidiosis. I have seen extensive conjunctival rhinosporidiosis. That is in Amardeep, Kollam only that I have seen. Very extensive rhinosporidiosis, slightly extending into the puncta and canaliculi, right? Yeah.
I think before we had lots of ponds in Kerala.
Right.
So it was more. But now the ponds are decreasing, that's why we are not seeing.
Yeah, the causative agent is Rhinosporidium seabury, and mostly I think, ma'am, it reaches the ENT specialist more than, it comes to the ophthalmologist. So ENT also deals with lacrimal sac and endoscopic DCR, so they also deal with it more. Until and unless it's over the ocular surface, something to do with the orbit and eyelid. Ma'am?
There are many ocular manifestations.
Yes, ma'am.
Eyeball is involved a lot. Everybody think about sac.
Right.
But it would involve conjunctiva, cornea, sclera.
Yes.
All parts
even
all are reported.
Eyelid
when
and even orbit is reported,
the
sir.
new ophthalmologists have to face it rather than just referring it.
Right.
So they should be aware of that. And madam, you can tell about your experience.
Right. So I had a very extensive conjunctival rhinosporidiosis in a young male patient, which I saw in Kollam. I went ahead excising the whole thing, actually. So he was put on ivermectin also subsequently.
It's a cauterized with the powder.
I did cryotherapy, sir. Yeah. I did cryotherapy, not cauterization, because didn't want to scar the surface. Correct, yeah. So I did cryotherapy, but actually after 3 months, it was extensive. I wish I had I'll show you if we have time at the end, because it's there in my conjunctival talk. He recurred with a small dot somewhere. And then again I excised and cryoed it, and so far he's doing fine. But it can always recur. There can be some amount of, the rhinosporidia which is remaining in the surface. It can always grow back, yeah. That is my experience, the worst experience with rhinosporidiosis.
Dapsone therapy will be effective.
Right. Okay, so we go to the case number 2. This is also very interesting. A quick case, okay? 35-year-old lady presenting complaints of redness, recurrent, 2 months. No pain, discharge or discomfort. All right. This is what she looks like. These are all common cases, and it's not actually an oculoplasty case here that I wanted to present. I wanted to present something which you all come across in your practice. All right. So what is this? Any student? I'm sure we have students here. Right? What is this? Straightforward case. Everyone should be shouting the answer now. Subconjunctival hemorrhage, right? She has a subconjunctival hemorrhage in the temporal bulbar conjunctiva of the left eye. Well, it's slightly extending, okay? Yeah, and she says this has been on and off for the past 2 months, all right? Now, this is how it looks like. Does it look totally like a subconjunctival hemorrhage for you? Yes? How many feels yes? With a resolving hematoma? 0 hands up. So it doesn't look like subconjunctival hemorrhage. Obviously, I will not present a case of subconjunctival hemorrhage. Sir, very smart. All right. Yeah, so more to the subconjunctival hemorrhage. There is something kind of an orangish lesion, right? An orangish pinkish lesion which is over here. All right. There are no feeder vessels. So as an ocular oncologist, the first thing that I would want to take out of my mind is it malignant or benign? Okay. So I look for the features of malignancy. Thick feeder vessels, whether there is any keratin sitting over here, because it's mostly OSSN that we find. Lymphoma, whether it looks like a salmon colorish. In lymphoma, again, there will be one vessel which really dips inside the tumor and then it vanishes. So nothing like that, right? The surface is fine. So what would you do? Observe. Just tell the patient, okay, we'll observe, let the subconjunctival hemorrhage settle down, and then I'll see you later. I'll give you some lubricants. What would you do? Not you both. I know what you will do. Anyone can come. Sir, you want to take over the case? We can do an
excision biopsy.
Excision biopsy, right. Yeah, that's what I did. Okay, so I didn't find it, well, there are, this is actually a very typical presentation of a disease, all right. So I did an excision biopsy. This is what I found. A student has to tell me what this is. No faculty's delegates will tell me. Yes, so what is this? An apple green? Birefringence, right. So this was a case of an amyloidosis which was presenting as subconjunctival hemorrhage. And trust me, amyloidosis actually presents with recurrent subconjunctival hemorrhage. So whenever a patient comes with recurrent subconjunctival hemorrhage, look for any lesions around it and just not that it is a hemorrhage. So in fact, she was diagnosed as subconjunctival hemorrhage earlier, 1 month back, and was asked to observe. The second, when she had an episode, that's when she was referred to me. So again, it's not over there. You all know amyloidosis, there are different types. Although it is a small lesion, it's a benign lesion, there are so many things which can go wrong. It can be even life-threatening. It can affect the heart. It's called the stiff heart syndrome. Okay, heartless. Anyway, stiff heart, whatever. So this is the panel of blood tests that we actually do. I'm sure, ma'am, you might, if you want to share your experience, what kind of amyloidosis have you seen in your practice?
I've seen a very peculiar amyloidosis where there was lacrimal gland swelling bilateral. I don't know if you have heard. Then it was first diagnosed as a lacrimal gland amyloidosis.
Okay.
And then systemic examination, we came up with a lymphoma.
Oh, I think you have presented it somewhere, and I remember this case.
It's a poster in the case. So
right. I
and
remember this case.
I had taken out the lacrimal gland. It was very hard, and you have taken it out.
Right.
But then he said with again it recurred, the lacrimal gland swelling, and with chemo for lymphoma, it's coming down.
Okay.
Because he came later for cataract surgery, and he had again bilateral lacrimal gland swellings.
Okay.
I told him, if you want, I'll take it out. But then he told me, with chemo, it will come down. You don't worry.
Right. Actually, yes. Yeah. So amyloidosis is very difficult to treat if it is diffuse. Marian, your experience?
Primary and secondary.
Right.
Yeah. Lymphoma. She told amyloidosis can come in lymphoma also.
Right.
So ideally get an evaluation by a hematologist.
Right. Yeah. So this was the list panel of things that we do, and well, you all know that it could be due to the light chains, the transthyretin, and this is how she presented. So this is the involvement of amyloidosis in the eyes. Okay, eyelid is the most common, orbit, conjunctiva. Ma'am told about lacrimal gland, even extraocular muscle, and levator palpebrae superioris has been defined. So I'm not going into the detail. This is the classification. So she had a primary localized amyloidosis, all right. And yeah, so I'll just show you a few cases. This was again a case where he was actually referred to rule out OSSN to me. He had undergone a biopsy here, which came out to be actually OSSN by the pathologist. Okay, but it came to me for excision. It was not looking like OSSN. Although pathology, the patient was carrying a pathology telling that it could be a OSSN, but it was not looking like that. You see the eyelid, everything was involved, and this was a case of a primary localized amyloidosis. This patient I saw in Kollam actually. She was referred to me for a ptosis surgery. Okay, of the left eye. But if you see, always avert eyelids whenever the patient comes in any form of eyelid issues. And this was the lesion that she had. This again the orangish pinkish lesion. And on evaluation, the other eye also had lesion. The right eye also had lesion. So this was a case of a bilateral amyloidosis. And well, I debulked it and she's doing fine. Another case, again, this is the conjunctival amyloidosis, very rare kind of presentation of amyloidosis. So another case of subconjunctival hemorrhage, a quiz and a trivia for the PGs. Infection is the cause. Lesion presenting as dark subconjunctival hemorrhage. Easy peasy question. So the last cash prize no one got. Sir is going to give cash prize if someone answers this. Right. No one got the cash prize. And this here, no age limit. We are all young. No generation bias. Infection is the clue. Yeah? Leptospirosis? No, ma'am. Okay. Biggest clue, immunocompromised. Kaposi sarcoma, yes. So Kaposi sarcoma can also present as subconjunctival hemorrhage, kind of a nodular lesion in the conjunctiva, okay. So many people answered, sir. Cash prize will distribute. 10 രൂപ വെച്ച് എല്ലാവരും കളക്ട് ചെയ്യാം പുറത്ത് പോകുന്നതിന് മുന്നേ. Okay, fine, all right. Case number 3, 45-year-old lady, swelling of the left eye, 1 month, gradual progression, painless, no history of fever. Okay, this is how she looks like. Okay, so you find that puffiness of the left eye, right? Yeah, even the right eye looks a little bit of puffy, more on the left eye. So a patient presenting like this, and she's got this classical S-shaped ptosis, right, of the left eye. You know the diagnosis by now. What? Neurofibromia. Where is the evidence of neurofibroma here? Plexiform. Come on. S-shaped ptosis. 2 months. No, neurofibroma will be long standing, right? Yeah. 2 months history. Pleomorphic adenoma. Bilateral. Puffiness. Okay. You mean something related to the gland? Lacrimal gland disease. Can we put it like that? Lacrimal gland disease, correct. Okay, lacrimal gland disease. So this is the clinical picture. Okay, so you can see the left is more big, large, enlarged, and the right is slightly enlarged. Okay, what would you do now? Treat her with steroids, antibiotics. And why did I ask for fever? What is the most common cause of enlargement of lacrimal gland? Ma'am, you want to tell them and just discuss? Viral dacryoadenitis. Ma'am, please, ma'am.
Yeah, I have never encountered fever patient giving Maybe after the fever subsides.
History of fever, yeah. So that's why we always ask for a history of viral fever, because viral dacryoadenitis, even bacterial dacryoadenitis can be present, but viral dacryoadenitis is more common. Okay, so she didn't have that. So what would you want to do next? Yes? What do you want to see? I'll show you. Ask me. Huh? Imaging. Okay, I'm going to show you the image. Yeah, so this is the imaging. So bilateral, okay? So more on the left, little bit less on the right. Bilateral, lacrimal gland enlargement, and it has gotten heterogeneous enhancement. So my favorite imaging modality in orbit is CT. We'll also discuss with ma'am, because we get a bony outline, you know. MRI is only very, very specific. First thing is CT. So we also get it with contrast, so that we can know whether there is any inflammation going on. So there is definite inflammation. That is this enhancement that you can see in the gland. Okay, ma'am, what is your favorite imaging modality in orbit?
Yeah, CT. I'm glad you stressed the CT.
Right, because we always get these patients walking in with MRI,
right?
Right.
Repeat the CT.
Right.
You
Yeah.
want to
So
do something.
yeah. So Marin, yeah, CT. Right. I just wanted to stress this here, because most of the time when a patient comes from a general ophthalmologist, I'm sure you want to do the best for the patient. MRI gives good visualization, but for an orbit surgeon, we consider the bone. All right. We relate to the bone if it has to surgery has to be done. We relate to a lesion to the bone, because a lesion, if it is causing bony changes, depending upon the bony changes in and around the lesion, we actually have a differential diagnosis. So it is so very important. So even if they come with an MRI, we repeat the CT in these patients. All right. So CT is cheaper. CT is good. So that is the first thing that we do for these patients. All right. So this is what was done. Now, what, ma'am? What would you do? What are the differential yeah, we'll discuss about the differential diagnosis.
You think of lymphoma, Sjogren's.
Yes.
Then what? Sarcoidosis.
Sarcoidosis, lymphoma, sarcoidosis.
Sjogren's. IgG4.
IgG4 related disease. No pain. There is actually no pain in this patient actually. Tubercular dacryoadenitis in India, that is also something that we would consider. All right, yeah.
There may be bone changes in tubercular.
Yes, there can be slightly bone changes. But ma'am, if you see here in the CT, the periorbita and the ostium is slightly irregular. Yeah, there is inflammation over there also. So that actually was in the differential diagnosis that I considered. So you would go for a biopsy, right? You would go for a biopsy. Everyone agrees, you go for a biopsy. Go for a biopsy. So how do we do a biopsy? Okay, so in this situation, we don't excise the entire gland. Obviously, you don't want to excise the entire gland. We do an incision biopsy, okay? So I'm just going to show you what all I did. So whenever we go for an, this is a very cosmetically, navigated incision biopsy, upper lid crease, very limited lid crease over here. Step-by-step approach, neat approach, and so we want to actually rule out infection. We want to rule out neoplasm. Okay, so the specimen will go for microbiology and also for histopathology. It's very important in any lesion if there is a suspicion of infection. We always send it for both micro and patho. So that is the periorbita, which is carefully dissected. Well, hemostasis, I would like the surgical field to be neat, because it's very important to identify the layers and get the things out very neatly. So that is the periorbita, which is being incised, and you can see the lacrimal gland, which is really, really enlarged, okay? Super enlarged. So different specimens are taken for different things over here. So this I took for genetic testing for tuberculosis, gene expert test, okay? This goes for the microbiology, for the AFB staining and Ziehl-Neelsen technique. This is for the pathology, a pretty good chunk for the pathology. So this is how we do incision biopsy and send it to micro and pathology. So the lacrimal gland gets repositioned, and then it gets attached to the orbital rim. You close it, and well, yeah, I'm sure ma'am you also do the same. Anything different? Same. All right, yeah. And yeah, so that is actually attaching the gland to the orbital rim so that it doesn't prolapse. All right, and then we close it. So this is how we do the incision biopsy. Okay, I'm just going to, sorry. Yeah. So this came out as a non-caseating granuloma. Okay, all the TB things were negative. Epithelioid cell granulomas were there. So now what do you do next? What are you suspecting here now? Sarcoidosis, right? Straightforward. What do you do next? Start treatment? Systemic involvement. Systemic, I can hear. Yeah. Okay, so what we do is serum ACE and serum lysozyme, okay, in the blood, and this was the HRCT which was done. So she had hilar lymphadenopathy. So this was a case of a young patient who presented with dacryoadenitis, and she was treated with oral corticosteroids, and lacrimal gland involvement in systemic sarcoidosis is around 7 to 16%. So these patients can actually walk into your clinic. Sometimes you might think it's just viral dacryoadenitis. You might treat them with steroids, but it may not actually subside. Okay, so taking a good history is very, very important. A quick last case. Do we have time, or should I stop?
Do we have time?
One more case, last case. 1 minute, is it? Oh my God. Okay. So this is 20. JP sir is very strict with me always. 24-year-old driver, defect in the left eye since birth. He is psychologically frustrated, bullied, social phobia, not able to work. He just came telling, make me look normal. All right. This is how he looks like. OS and ophthalmia and microblepharon. Can you do something about it, or you would just tell this patient, ki observe, no, chale jao, come after 3 months, 6 months, I'll see you in the OPD. What do you usually do for these patients? Refer, sit him, vocally counsel him, and then send them back home, right? Okay, so how do you evaluate in these cases if the patient really wants something to be done? Of course, I will do, for all patients, I'll do something. So we actually evaluate them. We do go and do the CT scan in a congenital anophthalmia, because now what you see is the surface contraction, right? The microblepharon surface is contracted, but usually they have a orbital contraction also, so 50 seconds. Okay, he has an orbital contraction also over here. Okay, ma'am, I'll just quickly go through it. Okay. Okay, so can you improve cosmesis? Yes, you can. This is a psychological trauma for the patient. And I always tell, even Arya, yesterday we had like 2-3 socket cases. And this gives me so much of happiness in dealing with socket cases, because you're actually psychologically treating these patients. They become socially so active after this. Until then, they're the most redundant people socially, not wanting to go out because of the looks that they have. All right, yeah. So what I did was a dermis fat graft in him. And you know, the eyelid has also to be expanded. So I did a lateral canthoplasty, expanded the eyelid, and a dermis fat graft. So this is how he looks like with the fornix formation suture. So this is the dermis fat graft, how we take it out from the buttocks, from the less hair bearing area. This is how it looks like, because it gives the surface and the volume. Okay. And I'm not going to play this, we don't have time. And this is how the graft takes up. Okay, it almost takes 12 weeks for the graft to take up. The entire graft will conjunctivalize. So this is the first week, this is like the 6th week, this is like the 10th week, and this is around 12 to 14 weeks where the entire graft conjunctivalizes. All right, yeah. So this is how he looks like. Good, right? Right, yeah. And he's so happy. Although he's a driver, he has aspiration to find a girlfriend, to get married, have a good life, find a better job. And yes, he did. All right, yeah. So, well, yeah. Few cases, congenital anophthalmia. So, in babies, never wait. Never tell them ki you can observe, you can do it when you have grown up, later, abhi to bacha hai, don't do anything. No. Right time is that time, the right time. And this is a child where congenital anophthalmia, as a small baby, he got treated. This was also after enucleation plus implant, after expansion of the socket. So this case was referred to me from Kollam. 27 days, the patient was referred to me. Do something about it. At 11 months, we started giving them, prosthetic eye, which was varying sizes. And she's absolutely fine now. Thank you so much.
Thank you, ma'am, for the eye-opening session.
Thank you.
Now may I request Dr. Rameshan sir to hand over the token of appreciation to Dr. J. Anthony sir. I invite Dr. V. Sahasranaman sir to hand over the token of appreciation. Dr. Fairuz madam, please. I invite Dr. Mahadevan sir to hand over the token of appreciation.
അങ്ങോട്ട് ഇടല്ലേ അങ്ങോട്ട് ഇടല്ലേ എന്താ ഉറപ്പ് അല്ല കുഴപ്പമുണ്ടോ സൈസാ
I invite Dr. Sahasranaman sir again to give the token of appreciation to Dr. Ani Sridhar ma'am. Sir, please again to Dr. Marian Polly ma'am. Thank you, sir.
Now we move on to the last session of Ashtamudi Ophthalmica 2022.
Hello. I'm going to project the eyes of a very famous person. You have to identify the person. It usually happens in all Ashtamudi Ophthalmica. Clue, these eyes. Famous person. Can you identify? Magnified view? Yes, magnified. Very, very famous. Everybody knows him. Not a single person in this. National, international? Tony sir. Okay. Who said that? Anupama, give her a sweet. No.
Now we move on to the last session of Ashtamudi Ophthalmica 2022. May I invite Chairman Dr. K. Mahadevan sir and convener Dr. Ajit Varghese to start the session.
So now we move on to the next vibrant interactive session of Retina. This session targets practicing ophthalmologists to get some take-home messages to apply in their practice. It also might help postgraduates to diversify their differential diagnosis. This session is chaired by none other than our retired professor from RIO, Professor Mahadevan, who is now the head of Department of Kollam Medical College. He is an active participant in and lead in many specialty meeting, interactive sessions and instrumentation courses. He is a voracious reader of ophthalmic literature and a versatile teacher and bagged many awards like the Women Oration Awards, Samman Award in 22 and from Federation of Ophthalmic Teachers of India. Then welcome sir to the stage. Our lead is Dr. Mahesh G, who is a well-known retinal figure in Kerala and national level. He is the head of the department and senior vitreoretinal surgeon at Giridhar Eye Institute. His educational background starts from Regional Institute of Ophthalmology, Trivandrum, vitreoretinal fellowship from Shankar Nethralaya, and holds fellowship from Edinburgh. He has many paper and poster awards like Shankar Menon, Shiva Ragdi, Tony Fernandez, name a few. Recently, Dr. Mahesh was awarded a PhD diploma in medical law and ethics. So we can contact him for any ethical and law practice also. What's more interesting about him is the fact that he's an authority in interpreting reports of investigative ophthalmology. I have personal experience from him. Welcome, Dr. Mahesh. Our panel star, Dr. Biju Raju, Dr. Ashok Nadraj, and Edwin James. Dr. Biju Raju is the consultant vitreoretinal surgeon at Dr. N.S.D. Raju Hospital. He is a postgraduate from Manipal Medical College and did his fellowship from L.V. Prasad. He has sound knowledge in the retinal field, and his area of interest are retinopathy of prematurity, retinal imaging, and vascular retinopathy. Dr. Ashok Nadraj, presently working at Little Flower Institute of Ophthalmology as a senior consultant. Okay, sorry. Yeah, updated to precise. He is well known to the fraternity. He has a fellowship in the anterior and posterior segment and is involved in many projects of diabetic retinopathy, silicone oil study, IV steroid for DME, etc. He presented 6 papers in international conferences and more than 15 at national and state level. And also has many awards in quiz video competition at national level. Welcome, sir. Then our Dr. Edwin James, our pride of Kollam Ophthalmic Association, took his PG from St. John's Hospital. He is an experienced phaco surgeon who is sound knowledge in medical retina. He has been in the field for the last 22 years, mainly in government service. His area of interest are refractive cataract surgery, other anterior segment surgery, and medical retina. Thank you.
We'll start. Yeah. Thank you, organizers, for giving us an opportunity. Nice to be back with the in-person meetings and our friends, retina groups. So I will show some 8-10 cases, and in each case there will be some take-home message. So that is what I want to think. Some are imaging, mostly imaging cases. So I will show one by one. First one is a case with around 15 years, 16 years follow-up. Okay, this was a lady at that time, 58-year-old lady. Right eye had a macula scar. Okay, this is a macula scar, and left eye was normal. And she detected accidentally that left eye, right eye was normal. That time nothing was done, and she was under follow-up. This in 2010 she presented with serous macular detachment in the left eye. That is a better eye with fluid in the macula. I don't have the OCT, but the angiogram shows a classic small ink blot leak in this left eye. So that time I thought, okay, atypical CSCR, central serous chorioretinopathy, and then I gave laser in that area. She was okay. Then in 2015 she presented with a hemorrhage at the fovea with defective vision and metamorphopsia. So at this time, if you see the angiogram, that original leak of CSCR was gone, but there is a in the ICG there is a hyperfluorescence suggestive of a polyp under the fovea. So she had subfoveal PCV, polypoidal choroidal vasculopathy. So this is the OCT of different sections. You can see that notched PED, and at that time we gave PDT, photodynamic therapy, and post treatment you can see that significantly there is improvement. So after the this is pre-treatment and post-treatment on the left and right. Her vision maintained at 6/9 and 6, and this was the post-treatment ICG angiogram. No polyp. Some dilated vessels are there. Other than that, no polyp. Then from 2016 to 19, she had a turbulent course. We didn't have PDT, but you can see that gradually there is a worsening of pigment epithelial detachment, and over time, that time no PDT was available, so we gave anti-VEGF injections in between, and you can see that after injection 6 months later again fluid is coming in the macula, so injection was continued. And the last picture, she is maintaining a vision of 6/12 and 8 sort of thing after 5 or 6 injection. So this is this case I have showed. This is a long follow-up, 16-17 years follow-up, and this is the spectrum of pachychoroid disease. So all of us should understand CSCR is not a simple disease. As we age, we can have different types of presentation in pachychoroid disease, and so I thought. So here after that recurrence, you can see no polyp but dilated branching vascular network. So I can discuss few things. My expert panel can contribute. This case I showed to highlight the pachychoroid spectrum over 15 years. It can present initially as CSCR. Many of us who had CSCR later can develop PCV and complications. So need a follow-up in all these cases. So that is the point I want to highlight. Ustad Ashok Nataraj.
Manish sir, can you go to the previous image, first image?
Yeah.
Fundus photo.
Oh, sorry.
Fundus photo, yeah. So you can see one in the infratemporal area. Is it a subretinal scar there?
Yes. Actually, that time, this year there is a small subretinal fibrin scar sort of thing.
Yes.
So that other than that, there were no some pachyderusson. Other than that, there was no evidence. So actually, this is something.
That is something, you know, which gives you a clue. Probably it was a peripheral PCV or, you know, or an old CSR even. So that is something, you know, which we have to keep in mind there. Actually, and as Dr. Mahesh said, you know, see, giving anti-VEGFs, only 30% of the you give an anti-VEGF, the edema regresses, the macular anatomy becomes normal. You do an ICG, if you do an ICG, only 30% the polyp has regressed. Now, remaining 70% the polyp never regresses.
With injection monotherapy, polyp will not regress, unlike that PDT.
Yes, so that is the most.
Repeating PDT also is a problem in the macula.
Yeah, so that is the most important point here, because, you know, you give an anti-VEGF, you feel the symptoms have reduced, signs have disappeared. That doesn't mean that the polyp has disappeared. It can come back at some point of time, you know, and you should always warn the patient at some point of time, and regular follow-up, importance of regular follow-up, and multiple injections at a later stage. So these are some of the very important points that you can see in this particular case.
Yeah.
I think the choice of anti-VEGF also will matter here. I think.
Yes, actually, definitely.
Have you considered micropulse laser as an option now that PDT is not available?
Actually, for central serous chorioretinopathy, I do give micropulse in the absence of PDT. PDT is not available. But in polyp, there is no literature evidence. I have given. I am not telling I have not given, but there is no literature evidence to support that subthreshold laser photocoagulation. The previous question that you asked, that the ideally Eylea or aflibercept is a better supposed to be a better molecule for intravitreal injection in polyp. Because I mean, the Everest study and all this study, it is as good as PDT, in fact. So the patient was not affording that. Now there is what is called brolucizumab. Brolucizumab has small molecule and penetrates deep into the choroid. So that also is supposed to be, even evidence is coming with the real world evidence of polyp. So Avastin is not a first choice, but the patient was not taking any other injection. I would have given, but if you see that after injection it is not going, that PED is not going, it is remaining more or less like that only after injection. That is why she is getting a recurrence after each injection. You can see that is coming back.
I think the polyp never goes away. That is
it never goes away.
That is why the PED is not.
So PCV is not a simple disease, even though initial prognosis is good. Vijay, anything to add?
I have just one doubt for you. How different is a pachychoroid spectrum from the peripheral hemorrhagic exudative chorioretinopathy, where you see large areas of suprachoroidal
hemorrhages in the periphery?
Again, exudations. Are they in any way related to PCV?
Actually, if you do wide field ICG angiogram, in many of these cases, there will be peripheral polyps in some of these cases. So it can be an extended spectrum of PCV. That is. Unfortunately, we do the angiogram only after the patient gets a bleed. Then the angiogram may not show anything.
And one good thing about this peripheral PCV is, suppose it is not involving the macula and patient develops a peripheral bleed. Now, once you clear the bleed, most of the patients, they settle. You don't have to give multiple injections.
That is because the polyp, once it ruptures, it thromboses. So that area will not create a problem.
So that way, prognosis is much better if you see in a peripheral PCV, provided it is not involving the macula.
Yeah. So that is case 1. So CSCR, don't take it lightly. Case 2 is a 28-year-old male. Actually, this patient was referred as some nerve problem, and somebody has diagnosed choroiditis. Any takers? This is a classic picture of one disease.
Torpedomaculopathy.
Torpedomaculopathy
with SRF.
So this is the classic torpedomaculopathy. Here, if you see the OCT, there is a gap in the, it's like a subretinal fluid in the OCT, but it is, you can see that the layers are not continuous in that area. It is something like an atypical coloboma. Biju has a double torpedo. This is single torpedo. If you see the angiogram, there is no leakage. It is only staining, and Biju can contribute a little more.
Yeah, this is actually a clinical curiosity. Whatever, we don't know why it occurs. There are hypotheses that it could be a melanotic adenoma of the RPE. It could be a defect in the emissary canal of the long ciliary vascular bundle. There is a hypothesis that it could be an RNFL defect, but OCT doesn't support that. Shields et al. Says that it could be something called a fetal bulge, at about 4 months there is a hypertrophy of the RPE in preparation for the maturation of the macula, which ultimately settles down. But in such cases, probably that change persists and some sort of an amylonotic material gets accumulated in the thing, and also choroidal vasculature. And this is actually a type 2 kind of an OCT picture. In type 1, we see attenuation of the outer layers and not the cleft is not seen. We had reported a case of a double torpedo where, you know, there's a the first torpedo was in this conventional location as in the horizontal raphe, which was type 1 on OCT, and the second torpedo was below it and it was looking like a type 2 OCT picture. It doesn't cause much of visual problem unless it involves some sort of a foveal into the foveal area, but usually they have maybe refractive errors. In our case, I had sent to Dr. Mahesh also for a multimodal imaging. He had a refractive error. Other than that, the vision was like this, 6.6, and no visual symptoms.
That gap that you see, it is not fluid, it's just loss of tissue.
Loss of tissue. It's a potential space or something.
But surprising, the retina is not conforming to that. Usually when you have...
Correct. So this case I showed, it is not choroiditis, it is not a tumor or anything. It is not a toxoplasma scar because it is not punched out. Right, it is not punched out. So these are some of the points. Vitreous is very clear, not a toxoplasma scar, just to show that such an entity is there. That is actually what is there inside we don't know. It is supposed to be a potential space. Something may be filling in that area. It is not a leakage fluid or anything like that. There is no disruption of blood retinal barrier.
No,
there will be something. It is not an empty space. I am not telling that.
No,
it's
like,
not
you know, if you look at retinitis pigmentosa CME, you see that CME like picture is because of loss of tissue. It's not fluid. So there are many situations.
Loss of tissue, that area has something, but
it
not,
can be like that. When you don't have increased vascular permeability or increase in leakage in that area, you cannot say that it's an active exudative fluid there. So that's how we say it is not that, you know, an empty space can be anything. Yeah, dark matter. That's what.
Dark matter. Okay. So next case is a 74-year-old man. Actually was referred as age-related macular degeneration. Vision was 624 in the right eye and 660 in the left eye. Little cataract, but otherwise, if you see the angiogram, I will come to the OCT. Angiogram, you can see some drusen, staining of the drusen, and some at the macula looks not ischemic. That central area is hypo. So this is the one. But if you see the OCT, there is gross atrophy of the central area. The ellipsoid line is gone. There is chronic cystoid sort of change in the macula, and the fundus autofluorescence is very typical that it is a hyperautofluorescent tract or a teardrop sign in the left eye. So this is usually we see in central serous chorioretinopathy. So again, I am coming back to the first topic, that pachychoroid disease. So this is basically a case of a chronic degenerative central serous chorioretinopathy in an elderly man. So don't think that all these people with CSCR will get old, no. So don't think that it is AMD. And so in some of the cases we have seen that with angiogram, if you see some leakage or something, you can give the micropulse and all, so that at least you can prevent further loss. So this is just to show that the CSCR can be seen in atypical CSCR can be seen in elderly. Yeah.
You are not considering it as AMD because it's not affecting the choroid. Is it?
Yeah, actually, yeah, it is, and it is a thick choroid. Usually AMD will have other features of thin choroid, all this stuff. So a lot of factors are, but autofluorescence is the one that gives you a clue.
That's what it said. Autofluorescence is a vital.
In many cases,
the most evident. The tract gives away the.
Yeah, you know how much extensive the retina is affected. That's
retinal,
what is shown
the whole area. We may think that it is only a small area, but the whole area is affected. So in autofluorescence, I just want to tell that the hypo area is where the RP is not there at all, not functioning. The hyper surrounding that is diseased RP. It is not a dead RP. So that is, if you see everything dark, that means RP is not there. And you can correlate that with the OCT. So that is just another thing, another take-home message. Now case 4, this is another one that we made some mistakes. 39-year-old male was referred as a choroiditis. Okay, so this is vision is 6.9, left eye 6.6. No history of any other disease, anterior segment normal, IOP normal. This is a left eye is normal, right eye inferiorly, outside the arcade you can see a retinitis, choroiditis sort of patch. So everything was normal, toxoplasma, IgG, IgM, all of us do, and then everything was negative. But clinically I thought, okay, retinochoroiditis and steroids with all these anti-toxoplasma, everything was started. And 1 week later, patient was called, vision was deteriorating, and that patch is completely gone. That patch is completely gone. So when I did an OCT, because vision was bad, there are multiple PEDs are coming, and when I checked with indirect, there was exudative RD inferiorly. So this is a major mistake that we do. Actually it was a central serous chorioretinopathy with fibrin, and usually we think CSCR only in the macula. Here the fibrin is outside the macula, nearly very away from the macula. So these cases, and OCT also shows similar findings suggestive of CSCR.
Initial OCT, there was no PEDs.
The initial OCT, I didn't take, I think there was no PD.
No PD.
No PD. After 1 week of steroid, and one thing that if you are giving without any conclusive evidence steroid, please call after 1 week. Don't give for 40, 30, 20, 10 and 1 month later you call. Don't do that. Always call after 1 week. That is the most important clinical point. And CSCR can have fibrin, which may look like choroiditis or retinitis, but the thing is, the media is extremely clear. No vitreous cells, no signs of this thing. These are some of the points that I want to highlight.
I think in OCT, see, it's just above the arcade. Many a time, if you can do an OCT just through that section.
Yeah,
because see, you should not think that OCT is only for ARMD. OCT is even for uveitis, retinitis, everything OCT is useful. So I think that is one thing. It's very non-invasive. When the patient comes, only if you can get the scan through that.
Away from the macula, you can do
you
the
can
OCT.
just outside the arcade, you can get an OCT also. That will give a good clue.
So this is an important point. Fibrin CSR can look like choroiditis or retinitis, and fibrin can be seen outside. That is a rare thing in this. Usually it will be seen inside the macula. So that is one thing.
So with fibrin being there, most probably it's a steroid.
Steroid, after steroid it's suddenly gone. But the worsening of CSCR was there.
Yes.
Then I just stopped steroid and did an angiogram, and I think I gave laser. It took nearly 4 months to resolve the exudative RD.
With fibrin CSR, we have to be more proactive. We may have to treat with epinephrine and.
Epinephrine I have given. But variable response.
Because fibrin can cause the subretinal fibrosis.
Which one? Fibrin. Yeah. Fibrin. If this is outside, so I am not bothered in the macula. I just conservatively manage. I gave some placebo and then manage. Suppose that fibrin was next to the macula fovea, I usually give epinephrine along with micropulse laser. This is this thing, so that I don't harm too much of this thing. But even thermal laser with mild power can be given if it is away from the fovea. Don't treat at the fovea.
And talking about CSR, I have had situations, and Mahesh knows very well about these things. So one thing I would like to say is, CSR is a great masquerade. It's just like syphilis, like you see in uveitis. It can come in any form. See, the classical teaching is if you do an FFA, you should not get a disc leak. See, it is a spectrum, like a uveal effusion syndrome, CSR, exudative RD. So, you should be very, very careful when you see a case of exudative RD. Even if you have a disc leak, there are a lot of situations which has still not been described in case of this spectrum. So, as Dr. Mahesh said, this is a situation before starting steroid, you should be extremely very careful.
And if you are starting, call after 1 week. Don't take too much of this thing. Epinephrine I have given, but I have 1 or 2 patients who had great weakness after starting epinephrine, and then I had to stop. This is probably metabolic change. You have to check the potassium electrolytes, very careful. And if the patient is already on AC inhibitors and all for hypertension, it may add. It's not a very,
What dose do you start epinephrine?
Theoretically, you start at 25 milligram daily. Then after 1 week, you can increase it after the initial this thing. This is what is described. I start with 25 milligram OD only. So this is another case referred as disc edema. Nothing, classic spotters. Okay, these are actually, this is a left eye has vision is 6/6. Went for some checkup and found that there is disc edema. Was referred as disc edema. Actually, in the left eye, the upper part of disc is blurred. There is a tinge of hemorrhage and some ILM folds are there. So this is the area, OCT through that area, some thick fibrous tissue sort of thing in that area, and OCT is characteristically leopard skin sort of picture, and field showed some corresponding to that there is a enlargement of blind spot. So Ashok bhai, this is actually I will tell you this thing.
Combined hematoma is one.
Combined hematoma. This is actually a combined hematoma of retina and retinal pigment epithelium. It's a classic OCT finding. I mean that fundus autofluorescence. The thing is, some people mistake it as melanocytoma of optic disc. That is one differential diagnosis because it's little dark, and two things. Surgery should not be attempted in this because you cannot remove the whole thing. And second one, it is not a melanocytoma because that location and the characteristic findings. So yeah, Biju.
Similar to this, I read a report on this one, combined hematoma, wherein the traction, exactly the same kind of a traction, but then the traction has led to vitelliform, not a vitelliform lesion in that patient. Which the authors, Yanusi et al., they postulated that because of the traction, the phagocytosis of the outer segments were not happening well, and that accumulated, the disc, outer disc accumulates, and then lipofuscin or something accumulates, and then, but that may be something you need to follow this patient for.
Yeah, I think when there is an ERM and traction, many people have tried surgery.
Actually, a long time back, before I came to know all these things, I have done.
Yeah, they have.
And nothing happened.
There are reports like ERM, they become better.
You cannot remove the whole thing.
Yeah,
and you will not. Patient will not benefit.
Yes.
Here and all, it is usually no secondary complication, just observe. So this is another. Yeah, Edwin.
Even melanocytoma can infiltrate the choroid and retina.
Yeah, but here it is all very superficial, no?
But the radiating folds.
No, if you have a doubt, always we will have a doubt. You just keep a visual field like this, and you can monitor with the field examination. I mean, visual field, whether that it is increasing or something like that. You can always keep the patient because nobody is going to do a biopsy or anything from that. So that is one thing. Now this is regarding HCQ. I will show some HCQ toxicity cases. Patient was on HCQ. This is the classic bullseye. Okay, the lower one is a multicolor imaging. It's a pseudo color. In fact, the upper one is a fundus photo. Lower one is multicolor. Multicolor imaging uses green, red, and blue, different wavelength, and it gets scattered by the different layers. The deeper one with blue. So red light. So you will see this multicolor as a better option to delineate the lesion. So this is and this is autofluorescence, and you can see that flying saucer sign in the center, and these two area there is ellipsoid disruption. Because of that there is increased backscattering here, so light is going too much. So that is ellipsoid disruption. And in fact, in HCQ toxicity, the ellipsoid loss is the early change, not thinning. I will come to that. So this is another, this is the multiple scans through different sections. And what we do is do a wide field section through all the macula and find whether there is any ellipsoid change anywhere in the. So you can always find out small ellipsoid changes, which is the highest, earliest change. So this is thinning, really thinned retina, and I have I will show you one more case. This is another case. Somebody has done a field and found that one or two scotoma are there, and this is the OCT, and the letter is given that there is foveal thinning and pre-maculopathy, stop HCQ. I just want to tell you that first of all, don't take the value of the OCT from the, this is a spectral OCT only. Time domain OCT, lot of people are using. Don't ever take a value of that. It is just like looking at the field without only grayscale. So based on this, don't give a comment, thinning and stop HCQ. HCQ is a vital drug used by rheumatologists with the least side effect. And if you use HCQ for 10 years, only 1% is likely to get complications. Only 1%. It is much safer than paracetamol. So a lot of people, based on just 1 or 2 spots in the field and then one OCT reading, that too time domain OCT, they ask the rheumatologist to stop the HCQ. This is one point that I want to discuss. Ideally, you should do a wide field scan and find whether there is any ellipsoid loss, and then if there is ellipsoid loss, correspondingly there is a field defect or scotoma in the field. So these two things, if correlates, then you can say probable HCQ toxicity and your patient can stop. HCQ is a very safe drug. Do not ask to stop the drug based on vague findings. And in fact, a lot of people, when I say my main job now is to do all these things and restart HCQ, because every day I get 2-3 patients, somebody has given one spot, stop HCQ, one little thinning, stop HCQ. Every day I see. So I have to, when you tell the patient you can restart, they are very relieved, because HCQ is a wonderful drug for many of them. And in SLE, it is a mandatory drug. So don't stop based on flimsy findings. So I need input from all the, I will spend 5 minutes in this.
So in Asian eyes, it might be perifoveal, even outside the artery.
Paramacular also.
Paramacular. So we need to do
like this wide field. Yeah, that's why I showed this wide field OCT. It may not be possible in every place, but at least you can do a section by section in the macula and find there is no ellipsoid loss. You have to do yourself one picture and see OCT thin, what is the value, central area is red, stop HCQ. Don't ever do that. This has been going on, and now we will land in medical legal cases for stopping HCQ and whatever.
And visual fields 10-2 is those standard.
Now it is 24-2. In Asians you have to do 24-2 because little, or 30-2 or whatever. Little peripheral field defects are there. But if there is a defect, kindly do a OCT at that corresponding area and see whether there is any ellipsoid. Otherwise, maybe just learning this thing. And all these rheumatoid arthritis, you ask them to do the field, it is actually, it is a torture. So, comments?
And surprisingly, visual field is quite sensitive.
Yes.
It's more sensitive than OCT in picking up those
early functional this thing. But the accuracy is the main problem in a visual field.
And one thing you should realize is, there are certain group of patients who develop HCQ toxicity very early. I have seen one patient after 3 months they have developed HCQ toxicity.
I told 10 years. The previous case I showed is only 5 years.
This is 3 months I have seen. What happens is, when they are on tamoxifen and certain anti-inflammatory agents, and the dose is very important because we give 200 milligram per day. That's a standard dose. Many patients, they are started on 400, 300. That's very important. You look at the dose also.
Obesity is another factor.
So these are certain things, which never crosses our mind, and you should not say that just because you have taken 1 year, you should not be, dogmatic like that. And very important point Dr. Mahesh said was the SLE, because it's the wonderful drug for this thing, and you should be very careful before saying no, you should stop it.
Thinning, don't comment, because thinning in HCQ toxicity is seen only in the last stage where everything is atrophic. So if you are telling HCQ OCT thinning, that means it is atrophic macula with very poor vision. Otherwise, don't tell that. Yeah.
What about the color vision defect? Is it associated?
Color vision idea, it is associated, but the color vision we have only Ishihara, which is not a good thing. Mahadan sir.
Ishihara
is
acquired color vision defects. You need funds with
and 8 to 10% of even males have color vision defects. It is only a corroborative, supportive evidence. Suppose you have some evidence in this, some evidence in that, and correlating everything, you can tell definitely there is a probability of HCQ toxicity. You can continue, but has to repeat the test after 6 months with everything. That is a safe answer. Not very fast. Not very fast.
So
I think
like any chemical, it causes cytotoxic damage.
In obesity, it can, even if you stop, it can get released from the fat and then long time. It is not that 6 months it is going to be blinding problem.
Basically
And if you have any doubt, like probable HCQ diagnosis, you can tell them to reduce the dose at least and repeat this thing after 6 months definitely.
I think, Mahesh sir, what is your opinion on multifocal ERG and HCQ toxicity?
Yes, I didn't show because multifocal ERG is very sensitive, but it gets affected by that cataract and all this stuff, and I use it as the fourth investigation if there is a doubt in all these things, and it is not available everywhere, sir. That is why I am not telling that.
So in a case of early toxicity that we detect, even after we stop, I think the
early
it binds
toxicity
to melanin, so it continues the
to
process
this
of toxicity.
So you can probable, and there is one more thing that I want to. Many of these patients have some other associations like old CSCR or some old RP atrophy, AMD or something like that. Then tell in your report that patient already has this thing. We will not be able to detect any HCQ toxicity. So better you reduce or change. Already.
I think it's mandatory. I do in the first year itself a baseline.
That is the best thing. That is the best thing.
That will avoid all the.
Yeah, but in SLE with macular, some other vasculitis or something, macular, lot of change. CSCR. Many of these patients might have had a steroid for a long time, and CSCR may be there. So you tell that you cannot assess whatever test you do.
The AO guideline on 2016 actually says color vision, time domain OCT, Amsler's grid are all thrown out. For evaluation. It should
Time domain is out.
It is
And
not
color vision is out. Correct.
It's not should not be done.
Yeah.
We have more sensitive parameters.
Yeah. Okay, we will go to the next case. Case 7, 24-year-old lady. What is this? 3/60. Yeah, actually, this was just to show one subtle finding in OCT. So this patient had defective vision in the left eye, 3/60 only, no RAPD. Color vision was abnormal in the left eye. If you see, there is hardly any change in the macula. But as I said in spectral OCT, from here to here, our ISOS junction is not seen. So there is a gross ellipsoid disruption in that area. So, and that area shows a hyper autofluorescence. But there is no fluid, unlike a CSCR. So this is something called retinal pigment epitheliitis, very subtle finding. It actually resolves spontaneously, but we do give steroid, and after that patient has recovered back to 6/6. Ellipsoid goes back. So any point, many of us mistake this for some optic neuritis because nothing is seen in ordinary OCT and other thing. Amadan sir?
Yeah, some patients may show even mild disc edema.
But
most of these is a viral prodrome, and just wait and watch.
I think it depends on what stage of the disease you see the patient.
Yeah.
Because when the earlier stage you will see this fuzziness of the RP and all that, and over a period of time it goes into atrophy, and many patients they recover also.
They recover good vision.
They
Supposed
lose
to be
vision. Self-limiting, and they recover also.
Only thing, when we don't see anything, we'll think about retrobulbar neuritis, right? And treats with that steroid, and this improves.
Yeah. And
so we are happy. Patient is happy.
And another thing, in these cases with parallel prodrome, it's important to look for AMN and PAM also.
Yes.
And those subtle findings also you should keep in mind, because they will also look normal.
My suggestion is some technician is doing, and only the central OCT picture is there. Don't. You have to look at the sit in front of the machine and just do a serial scan all around, and then see. You will see much more things, especially cases like this.
And especially in the setting of coronavirus vaccination and viral infection, that is very important.
I had one.
Yeah, it's very important.
So that is one. Case 8. HCQ was there, but I think it is. This is another interesting case. This is the right eye, left eye. Vision in the left eye was 6/24 only, that eye. So this was the OCT. Right eye normal, left eye fluid is there. Serous macular detachment, no doubt. So it was a CSCR-like picture. Fine. Autofluorescence, perfect. CSCR-like picture. Hyper-autofluorescence and everything. So I did an angio. Right eye was normal. Left eye had something like a leak here. This area. Something like a leak. So I gave little laser, and then nothing happened. Fluid was remaining like that. Then one of my fellows came and said there is something else. You can see that it is bulging from that horizontal section. So this is called dome-shaped macula, DSM, dome-shaped macula, and this is very typical. If you do a vertical scan, it is flat. But if you do a horizontal scan, it is bulging. So in dome-shaped macula, fluid can collect under the fovea, and we mistake it for central serous retinopathy.
Patient is myopic?
No. Oh, sorry. I don't think. Yeah, myopic. Myopic. Minus 5. Actually, left eye has less. And in fact, if you see from distance, there is a vertical line. Here you can see the choroidal vessels more clearly, and not here. Actually, that even the other eye, near the peripapillary area, choroidal vessels are there. And that is because the eye goes like this on the back. There is a curvature. So that is why DSM, very careful observation is needed. But this I treated with laser, nothing happened, then I stopped everything. So I think after some time
spironolactone and other things are
that time in the old case.
It was. I have one case where it responded probably.
Epilerenone you have given.
Not
okay.
epilerenone, spironolactone. There are
maybe that
reports
is
in
another
dome
option.
shape
This is the
macula.
shape of the posterior segment. Spironolactone better is epilerenone, less side effects. Now it is there. Case 9. It was referred as CNVM. Somebody has advised injection, as usual. That is our main thing, no? So this is right eye, left eye. These are all spotters. There is no other question. So there is a hyper reflective area at the fovea. So why this is not wet AMD? Simple thing that foveal contour is maintained, nicely maintained. If there is a CNVM here, it will be like this. So foveal contour is maintained means it is some degenerative thing, not exudative. So that is, and autofluorescence shows hyper autofluorescent material in that area. This is adult onset foveal vitelliform dystrophy, actually classic finding. So some cases it will be a little more bulging, then foveal contour will be little up. But usually the vision will be 612, 6/9 like that. It will not be bad. So this unnecessarily need not be treated with injections. That is thing. Now we have OCT angiogram which can show some network in that area. That is another thing. So sometimes this lipofuscin material get absorbed, and you will see something like a fluid in that area. Even this is not edema because it is the foveal contour is nicely there. It is not edema. It is a degenerative condition. So many of these patients maintain good vision 6/9, 6/12 like that. No need to treat anything.
I think autofluorescence is very important.
Yes,
hyper autofluorescence that is the most important.
Hyper-autofluorescence in this area is extremely important. But later, if you see when the matter get absorbed, you will not see any autofluorescence. But the contour of the fovea gives you the clue that it is not very, and the good vision. So this is. So that is regarding adult onset foveal vitelliform dystrophy. It's a deposition of lipofuscin in the center, maybe unilateral or bilateral. Now one simple case, Jagadish Varnole, one simple case of Odi Navasanipikana. Okay, this 7-year-old girl, gradually progressive defective vision, 1 year, associated with headache, eye strain and nausea, fever 11 months back. And somebody else diagnosed mutes, VKH and referred. A patient was treated by DEXA and past 1 month is on steroids, Vislon. So vision was almost 6/9 with only little hypermetropia, plus 0.75 or 1. So everything was normal. Toxoplasma IgG everywhere it will be positive. When we don't want, it will be positive. That is the main problem with Toxoplasma IgG. When we don't want that result, it will be positive. So and these are nice pictures. This is Optos white field imaging, and this is white field autofluorescence. You can see some dot echoes, hyper-autofluorescent material sparing the disc. Around the disc peripapillary area, it is not there. And in the OCT, there is serous macular detachment like picture with little cystoid edema. So, yeah. So this is the other eye, exactly similar. Okay. So if it was mutes or VKH, vision would not have been 6/9, first of all. Then this is the other pictures, and OCT different layers. In fact, there is something on the photoreceptor area. It is all thickened area, photoreceptor area, and little cystoid changes, large sections. Disc RNFL normal, and there is no leakage in disc or in that area. Some staining of that hyperfluorescent dot is there. So in any case of inflammation, leakage or mutes or anything, there will be disc leakage or disc staining. Okay, that is the most important thing if there is inflammation. Here nothing was there. So I sent it to some intelligent people are there outside Kerala. So I sent them and the two people immediately answered. So it is a simple diagnosis called autosomal recessive bestrophinopathy. Okay, simple diagnosis. It is bestrophinopathy. Don't treat all these things with steroids and load the patient. Actually, we did ERG, EOG, multifocal ERG shows some dip in the vein, waves, and ocular EOG shows little change in the Ardens ratio. So why I showed this is a very rare thing. I came to know after I sent it to Vinod Kumar in RP Center. Is a brilliant guy. So I sent it to him. So immediately within 5 minutes he told this has been published. Bestrophinopathy. Bestrophinopathy is a spectrum, one end of a spectrum of disease, starting from Best disease, autosomal adult onset vitelliform dystrophy, and this bestrophinopathy. All these are one spectrum of diseases where more EOG is affected. EOG is affected because of retinal pigment epithelial change. Unnecessarily don't treat with this steroids and all. And this is due to mutation of BEST1 gene. So I just wanted to show you. Some of you may remember it sometime in life, so that this may be that.
And Dr. Mahesh has told
us.
Yeah.
28 seconds remaining. I have finished. Thank you.
And Kerala. The one point here I want to make is for uveitis, it's very important to do an ICG also.
Yes.
Because many a time you can detect choroidal granulomas easily in ICG. That is something which is underrated. Because when you say uveitis, you don't think about ICG only.
If you are doing angiogram, better to do fluorescent ICG together.
Because this case, if you do ICG, you would have found that it was normal. It was not uveitis.
Yes.
So that is very important.
Here disc also was normal. So some of these rare things you can remember. Some of the rare things we remember by seeing it only. So
take home messages and the conclusion, I would say he has shown so many black holes in the retina, too many of them. Now I would say you do OCT, serial cuts, even outside the fovea. That is one take home message, I think.
Yeah.
And then call the patient after 1 week. Don't prolong 1 week. So you can detect some more pathology if the condition is worsening. That is one. And there's bizarre manifestation of CSCR. So you have to be aware of it.
Yeah, actually, my take you don't need all these equipments to come to this diagnosis. If you sit in front of the OCT machine and do yourself, you can make out 90% of things you can make out. So
and another thing, HCQs, don't stop the HCQs unless you are very sure.
You write probable HCQ diagnosis, no evidence of HCQ toxicity.
Continue.
And cannot be assessed. These three may be my inferences. No HCQ toxicity seen in any of these tests. Probable HCQ change, but need follow-up. 3, definite HCQ stop. And 4th one is probably underlying other diseases are there. HCQ toxicity cannot be made out. So these probably 4 lines you can.
Fine.
Ayo, sir, that's optic nerve, sir. This is retina. Now a lot of cases, I think medical college people may be knowing, a lot of cases are coming with optic nerve involvement, optic neuropathy, and unfortunately they are not listening to us. We have tried, a lot of people, that new regimen, it is gone. Actually, if you don't stop, it is gone. Already they come very late. It's a blinding regime. I don't know why till now that government has not looked at that aspect. They'll and that's what pulmonologists, they don't listen. I am sorry to say, I have sent 1 or 2 cases, but they won't listen. They think that this is a very safe this thing. Actually, this was discussed in one of the KSOS meetings, and something to do all these things, I don't know. The pulmonologist has to change the regimen, otherwise more and more. I have at least 5 or 6 people. One hairdresser from Tribunithura area became blind, one Bihari became blind.
200 milligram per day given as a night dose. That's the most ideal.
Yeah, actually, yeah. 400 is little high.
400 is a little high. Even 300 is high. No, 200 is now the cutoff.
Thank you, my panelists. Thank you.
May I request Dr. Mary Kuriakos, Madam, to hand over the token of appreciation to Dr. K. Mahadevan, Sir. Dr. Mahesh, Sir. Dr. Biju Raj, Sir. Dr. Ashok Nadraj, Sir. Dr. Edwin, Sir. The lunch is ready. You can take the food and come inside and enjoy the music.